protect activity by making testing really easy for those populations who need to go out to work and for their livelihoods, but equally need support potentially if and when they have to self-isolate. Of course, that is happening less. Jill's right, the vaccination program's been a great success, but so has Test and Trace and Protect. And so we have 5 projects. The first has gone live in Anglesey, actually, and it followed the incidents that we had in Anglesey a fair few weeks ago now. But that programme is nice in that it wraps around the testing kits through the LFD and making it really easy for the population. Also, an extended food offer to help those in need and in that Protect space. Also working with fuel poverty colleagues, because we know that's an issue, and while it's getting a bit warmer, well, a little bit warmer, not completely yet, it will get cold again, and we need to support these individuals. The financial inclusion work, and thanks to our partners in the Citizens Advice Bureau as well, are supporting us hugely in Holyhead, and also focusing, of course, on the mental health elements, which we know is a concern. So the 5 projects to date are in Holyhead, Bangor, Denbigh, Wrexham and Flintshire. And of course, we do hope that we will have further opportunities going forward, but we've received support for those. On the variants, you'll see on the slide that there's significant work underway. I would say that the system across North Wales is working well. So we're working with Public Health Wales. Samples from North Wales which are positive get the genomic sequenced, and from that we can see the variant element if there is a need. Of course, one of our main risks at the moment is the fact that we have a number of returning travellers, and as the world opens up with travel, of course that will probably be a challenge going forward. But the partnership works together, so it's very much Public Health Wales with the lab space and the CCD support. The local authorities, the EHOs support us with any cases where we need to look at specific histories, and of course the regional hub as well supporting the coordination. So I would say that there's significant work in that variance of concern. We're also working currently on our refreshing our plans across North Wales, including the rapid testing plan, which of course we've tested through recent incidents. So maybe I'll stop there, Jill. Thank you. Diolch yn fawr.
Thank you, Teresa. Just to move on, we have reported back at board, and it is within our infection control annual report, a number of outbreaks and our opportunities and ambition to reduce these as far as possible and to learn from them. So as part of that, we have reinvigorated our Safe Clean Care programme with our ambition to adopt a zero tolerance approach to healthcare associated infections, upholding our values of doing nobody any harm. So we are developing this through a strength-based mobilisation programme, and we are describing that as safe, clean care and harm-free care. There are a number of work streams that are aligned to that, but we'll know when we are successful, when we see clear and visible evidence that infections are both reducing, they're on a downward trend, and they are staying on a downward trend, and their absolute minimum. Improvement is sustained, and that everybody understands their role in reducing the risk to healthcare-acquired infections. The final point there is to have as part of our processes that there is both clear escalation, which we have built into our programmes, but that we are confident that that is being used effectively across the organisation and that there are consequences for not complying. We do have 3 work streams associated with that. All of those are led by senior personnel within the organisation, and we have excellent clinical engagement. So they are outlined as a safe place, safe space and safe action. I would like to acknowledge as well that we've had excellent support from colleagues in health and safety, workforce, TTP, our estates colleagues around the cleaning standards, as well as clinical colleagues, and pharmacy colleagues. So I'd just like to acknowledge that is a all-encompassing programme which touches every part of the health board, from mental health, primary care, into secondary care. Coming on to vaccination, the numbers are there in terms of the vaccinations given, and the split between first doses and second doses. This is an ever-changing programme. The JCVI guidance has changed on numerous occasions, so that is the vaccination guidance that is received across the 4 nations, which has required us to respond very quickly to changes in that guidance and ensure that we are reaching out and getting the right vaccine in the right arm. One of the points I would like to make here is we have worked really collaboratively across all systems, not only to deliver the vaccine, but to ensure that we are reaching those hard to reach groups, to ensure that we equitably apply the vaccination principles. You'll see in the next slide our progress against each of the cohorts, and we are making good progress, and we do feel we're on target to achieve the national aspiration for July. Continuing, we are working with local authority partners to consider what our plans for the future vaccination programmes are. So we are working up those plans of how we can sustain this progress if there should require a third vaccine and how we would be delivering that. That includes working with our local authority colleagues to consider how parts of vaccination centres may remain open, particularly in the east. Keen to ensure that we get an appropriate geographical spread. We are working with our primary care colleagues who continue to deliver the vaccine, but we're also conscious of the storage that we need to consider with some of the vaccines, which means they are not as easily deployable as the AstraZeneca vaccine. As a consequence of that, as I say, we are looking at opportunities around local vaccination centres, working really closely with our partners to ensure that they are deployed in the best possible locations so we have the widest reach. Really conscious of the geography of our area, and also the ability for people to be able to access the centres is really crucial moving forward. So the preparation for the any September boosters is being made. We're working very closely with Welsh Government as what those scenarios might look like, and we're already developing our workforce plans as to how we could deploy that in the autumn months when it's likely to kick off. I'm happy to take any questions you may have on any of that, but I'd like to endorse as well Teresa's point that the team working across TTP, vaccination, and indeed the preparedness around the continued preparedness around COVID has been a fantastic team effort.
Up and out, Jill. So first of all, Medwyn.
Thank you
very much, Chair. Thank you, Jill. Of course, there is good news here with the vaccine and the work that has taken place in distributing the vaccine. Just wanted a clarification really on the slide which shows our hospital input. And it states there that there are 58 inpatients, appears that they're in the West, and I understand there may be issues around publishing papers some days in advance because the date of this paper is the 12th of May. Jill mentioned earlier that the position has changed again since then. Now, according to the slide, the line flattens out and then raises up. Is it possible to have some certainty that the numbers in the West are decreasing? Thank you.
And Chris, do you want to, well, I've got Chris and Jill. Chris first.
Jill, I can pick that up from the dashboard right now, if you like. It's just loading. The total across all 3 sites plus community hospitals this morning, Medwin, was 44. In the West, it is today 25 currently being treated as confirmed COVID in hospitals in the West.
Thank you very much.
Does that satisfy your question, Medwin?
Mark, Chris has answered what I was going to say, so that's fine.
Medwin, are you happy with that? Or you wishing to comment?
I'm happy, Chair. The question's been answered. It was just a question of, given the situation in Ysbyty Gwynedd with the outbreak, was this still going in the right direction, basically? But yeah, the question's been answered there.
Okay, thank you. And certainly in terms of this week's report, there was we were down to 0 in terms of patients and staff in terms of new cases, weren't we?
We were.
Okay, thank you. Okay, Lynn, next, please. Yeah.
Good morning, and thank you very much for the presentation. I have 2 points I'd like to raise. The first is, throughout the news yesterday, it said how well Wales had done in comparison to our other colleagues throughout the UK. And would you like to add a little bit more about how to be proud of all what we've done for the vaccination? So if you could maybe just elaborate on that. My second point is all these travellers travelling back from the amber areas. Where do we fit into the quarantine and the checking and the reporting of those instances? Thank you.
So Lynn, if I may take the first one, in terms of how we can be proud, I think we can be really proud in terms of the percentage of vaccines that we've given across Wales and across North Wales and are continuing to do so. One of the things I should have called out, Lynn, as well, apologies in the presentation, is that we are still working on 12 weeks for the second vaccine in Wales, which is in line with our Welsh Government guidance and actually does reflect the lower incidence that we're seeing in Wales of some of those variants of concern. But in terms of where we are seeing those numbers. They are continuing to rise, and we are seeing a very good uptake. The other point I would raise is that we are now not relying purely on letters to draw people into their vaccine. And you may have seen very orderly queues outside of our vaccination centres as we're calling people in via text messaging and direct messaging. So I think there's a lot to be proud of, Lynn. And I would say that the ability for us to be able to respond to the changes in some of those rules, which we acknowledge cause some significant stress for people who's particularly in primary care, whose appointments were cancelled at short notice as we were anticipating changes in the guidance from AstraZeneca to Pfizer. And our teams responded phenomenally to those in terms of switching over and getting the messages across. Okay. Apologies, can you repeat the second part of your question?
It's people coming home from amber areas and being quarantined, and where do we fit in as a health board there?
I think Teresa wants to come in on this, Lynn. She'll probably have the most up-to-date information.
Thank you.
Yeah. Michelle, right. I prepared a report earlier for another meeting this week. I was just trying to find the numbers. I think it was Monday I prepared this one. And on that day, you're right, there were over 3,000 travellers isolating in Wales. And of those, I think there was 583 isolating here in North Wales. So you make a very good point. We work with a national team, which is the national arrival team for Wales. They support in terms of some of the work through and contacting colleagues. But then if there are any issues, there's also the regional and local links. So we certainly get involved if there are any issues in relation to tracing some of those individuals and making sure that they are isolating. We also work with enforcement and compliance colleagues across North Wales. I predict a surge in cases, though, as we go forward, potentially red and amber. So we're having to watch both because, of course, countries change. recently you'll have seen the change in places such as Nepal. We have to be alive to that within our team. We work with the national, so it's very much a partnership activity, I would say, and something I'm proud of. So I think the national team in the Welsh Government have set up with Public Health Wales, the regional team and all the local authorities, and then all the partners around that as well. I think we're all working on this agenda, but it is one to watch as the numbers are bound to increase, with a bit of a first surge expected with half term, of course.
Diolch yn fawr.
Oh, Giles, see you've got your hand up. Do you want to come in before I come on to other members?
Diolch yn fawr. I just, to Lynn's first question, wanted to particularly acknowledge the support we've had from our primary care colleagues, from our staff recently retired and current staff who have been redeployed so willingly into the vaccination efforts, but also to acknowledge the supreme effort and support from our volunteers, who have really helped us along in lots of practical ways. And just whilst I am saying thank you, I'd like to acknowledge Dr. Chris Stockport's time as Gold Commander and say thank you, and thank Jill Harris as she takes on the role as Gold Commander with regard to our ongoing COVID-19 response. Clearly, it's a huge Betsy team effort, and without our staff, we couldn't have made the progress that we have. So my final thanks is to them. Diolch yn fawr.
And the board will wish to echo those thanks as well. Thanks, Joe. So we'll now come on to Avion. Avion?
Yes, thank you very much, Chair. Just a brief word in Welsh, and just as has been said, the vaccination programme has been very successful across North Wales, and I'm sure the public are very grateful to our staff for their work over past months. But Jill's reference now to looking forward to the autumn, and that's when, of course, the booster jabs will need to be organised. And at that time of year as well, we normally arrange vaccinations for flu. So that's going to be an added challenge. May I ask, please, what will the arrangements be for that as well? And whether plans are already in place, and or whether are you collaborating with local councils on that? Thank you.
Diolch yn fawr, Evian. Just to confirm, the plans that we're putting in place for the booster programme, absolutely, we are linking in with local authority colleagues, not least so that we have local vaccination centres where they are applicable, in the right places to deliver to our populations, and also where we might need pop-up centres as we've done during the original programme. In terms of the flu, yes, we are planning in conjunction with the flu, and there are, and Teresa may be closer to this, but there are trials taking place about whether we can, moving forward, deliver the flu and the flu vaccine as well as any booster at the same time. For our primary care colleagues, that will make a significant difference because they can literally do them both at the same time. I saw Teresa did put her hand up. She may have more information on that, but I am not aware that we've come to some conclusions. So we're working on both bases, Ivy, and whether there may be a small time frame between giving the flu and any booster, versus whether we will be able in the future to give them both at the same time. And you'll also be aware there's a lot of work being undertaken at the moment to say which vaccine would we give in the future. So we're working through all those scenarios, and as I say, working closely not only with local authority colleagues but wider to ensure that we get that at the right places, but also that we are targeting those that are harder to reach. And Teresa might have more detail on the flu and the booster jab.
Diolch, Jill.
Thank you, Jill. I don't think I have anything further to add today, Avion and Jill. We're still waiting. The discussions are ongoing, but we do have good information through, and the system is working communications-wise. We're still waiting, but by the next board meeting, we'll have an update for you. Thank you very much, Teresa and Jill.
Okay, jump about. Lucy.
Thank you. I just wondered if we could have some clarity, please, on the process that's going to be followed in Wales for the vaccine passport. I think it might help members of the public, I suspect, are quite confused over the arrangements in England versus here in Wales. Do we have any further detail yet on timescales, etc.? Thank you.
Apologies, Lucy, I was on mute. In terms of the vaccine certificate and the timings for those, there is actually, this is actually picked up on the Welsh Government website. There is a website looking at getting a vaccine certificate for international travel, gov.wales, and all the information pertaining to this is within it. That does, we will clearly be updating our own website as that becomes clearer, but that is the process to access at the moment.
Thank you, Jill. So does our website at the moment and communications make clear, are we directing them basically to the Welsh Government website? Because my concern is that we'll end up with people going to their GP and expecting the certificate from them.
Thank you, Lucy. I will double check that today, Lucy, and if it isn't, I'll make sure it's uploaded later today or this morning.
Thank you.
Thanks, both. A couple of questions from me, Jill. So in terms of the vaccination programme, and as you know, I recognise this has been a somewhat moving feast of late. Do you envisage a point at which we're going to be able to indicate when we anticipate the remaining elements of vaccination, for example, around second doses, is going to be clearer to us? And if so, when we can share that with board, but also stakeholders? I don't know how much correspondence you're in receipt of at the moment. I'm not in receipt of much, but I'm surprised by that, particularly in terms of second doses.
So in terms of the second doses, Mark, we have been seeking clarification because you'll understand there's been quite a lot of questions given the English position that they were bringing forward the second doses. Yeah. And the Welsh Government stance is at the moment, we are continuing to look at the 12-week interval. Clearly, it's around those times. So some people might be slightly earlier. We are continuing to keep a watch on that because that guidance may change at any time. So I could provide you with the information today, Mark, that might change tomorrow in terms of, yes, we do have plans for those second doses as the interval stands at the moment.
Okay, all right, thank you. And then just in terms of the plan moving forward, again, I know this is under consideration, but in terms of how we are going to deliver vaccination, for example, the means of distribution, and I know there's been conversations going on with primary and community services too. Again, when do you think we'll get a clearer sense of that?
So thank you, Chair. Those plans are being worked up, and I think we did make some progress just this week, particularly in the eastern part of our geography, Mark, in terms of ensuring that we have those local vaccination centres in place. And that these are, so we're continuing to work with them, work out how we can extend those. I think it's really important. We've also worked up what workforce we may require for the delivery of the booster jabs and where that might need to be, and continue to work with our primary care colleagues. We do have an indicative plan, but it is really draft right now. We are sharing that across other health boards, or testing it across other health boards, I should say, to ensure that we are gathering best practice. Equally, we are sharing that with Welsh Government colleagues to ensure again that we're reflecting what we know as now is included within the plan, and we are working that through with our gold group, which includes local authority and other stakeholder partners, when we meet to just test that through. So it's not finalised, Mark, but we do have an indicative idea of what the workforce might be, what the split might be, and we've already started to plot out where the local vaccination centres are.
When do you think, Jill, you'll be able to share that with board?
I think in terms of sharing a draft with board, I'm hopeful we'll be taking something to the executive team in the next 2 weeks. That is on the basis that we'll have received some feedback, and then I'll be happy, albeit recognising that this may adjust after receiving feedback from executive colleagues, that to share it with the wider board.
Okay, all right, thank you. So thanks, Jill. I have no other questions showing, Jill, so we'll end it there, and thanks for the update that you've provided. So we'll now move on to 3.2, which is, I'm afraid, with you again, Jill, the Infection Prevention Annual Report. Of course, you can take it as read, Jill. They are, of course, or it is a lengthy document, so please take it as read, highlight anything you want to highlight.
If I may just highlight a couple of points, Mark, I was going to take it as read rather than go through it in detail. I would reflect this as an annual report, so it's looking at the wider infection prevention control across the past year, and also considering moving forward what our priorities may be. It does go into detail around the Safe Clean Care programme, for example. But I do want to start off by thanking everyone that's been involved in developing learning across the pandemic. It's really brought the infection control, prevention and control to the forefront of not only how we serve our community, but also how we deliver care. We've seen some great work, and we've seen some really innovative work, including the introduction of face masks very early in the pandemic, as board members will be aware, but developing those face masks so that recognising that actually it takes a lot of the personal touch away, having a mask across your face. And so the innovative care that we've seen in terms of see-through face masks, so that particularly some of our more elderly community can actually see the faces of the nurses that are there to support them. I'd also like to point out that whilst it doesn't always feel like it, we have seen an improvement in our overall infection rates. And we are one of the better performance, particularly around MRSA and MSSA. And we do want to ensure that learning that we've seen across those infections is embedded across all of our infections, so that we're reducing them overall, hence the principle of harm-free care. Acknowledge as well the work that the health and safety and organisational development that has supported this programme, particularly in terms of the work around fit testing, and also reaching out to our colleagues across the organisation, including our staff side colleagues who've been fantastic in getting the messages across, but also supporting those messages. We have, as I say, launched the Safe Clean Care programme, and I'm happy to take any questions that there may be. But I think we need to respond. Coming back to the Stronger Together programme, we have to influence over 1,700 staff, hundreds of thousands of patients and citizens, and we do need to continue to move this programme forward, recognising the level of challenge that we have. We have seen significant isolation challenges, not least down to our estate. That has led to us having to remove beds to increase the space between patients as part of this pandemic. We've seen a lot of work moving towards virtual technology to ensure our patients are keeping in touch with visitors, but equally that we've been able to keep in touch with patients that require our care that didn't necessarily require coming onto our sites. We do still have significant challenges to reach out to all of our staff and engage to continue to make progress across this agenda. And the work that we are doing with the Office of the Medical Director to embed some of this as standard practice is being undertaken in a much more joined up and rapid way. We do continue. It has been a struggle to ensure that we've had decamp facilities so that we can continue with the deep cleaning, which allows us to have confidence in our environment. That has remained a challenge, but we do continue to do it, and we are continuing to provide a focus on that in our monthly strategic group conversations around infection prevention. We've worked very closely with our domestic services to ensure that cleans can be undertaken, and they are working with us to ensure that the new cleaning standards will be embedded across the organisation, and we are at the table in both developing those standards but also ensuring that they are implemented. Our plans are set out in the appendices. If there are any questions relating to the report, I am happy to take them.
Okay, in route questionnaire, any questions? Lucy. Lucy.
Yes, sorry, technology. Thank you for that, Jill. It's a fairly substantial report, and obviously there has been a huge amount of activity and huge challenges as well in relation to infection prevention and control this last year. And following up from some of the things that you've just said, I think it is really important that we call out the behavioural elements that are referred to on page 18. So specifically things like, we control this pandemic with our behaviours, and no one acts or behaves rationally as expected all the time, recognising that our workforce and our members of the public as well, we're all tired, and this has been particularly challenging. So I think that behavioural element really needs to be, can't be overemphasised, basically. In relation then to some of the lessons learned, I am concerned that the report doesn't necessarily draw out the lessons learned. There's references to common findings and themes and contributory factors, but they're not actually the lessons that we've learned from some of this. And if we can't identify those lessons learned, we're not going to be implementing and embedding that learning behaviour then. So that does concern me. In reference, for example, to the 732 RIDDOR reportable COVID infections, it states that remedial action has been taken, but it's not clear from the report what the remedial action actually was or how that's going to be monitored. And I think it's also important to highlight the Health and Safety Executive Improvement Notices that we've received in relation to that, and provide an update against those as well.
Chair, I don't know whether, I think Sue is back from leave when she wants to pick up she does, the RIDDOR reportable, and then I can go back to the lessons learned, if that's okay.
Okay, thank you. Sue.
Okay, thank you. So in terms of the RIDDLE reportable, how they are managed and how we are able to demonstrate delivery against the actions from them. So I suppose board members will know, and definitely quality, safety and experience committee will know in detail. We have been working very closely with the health and safety executive around our reporting. We took a decision very early on in the pandemic and agreed this with the health and safety executive, that we would report any cases where there was a potential for infection with COVID to have been linked to the workplace. And as a result of that, we have reported a considerable number of RIDDLEs. We've also been in liaison across Wales, so the network across health boards in Wales, really to develop that kind of once for Wales approach. More recently, Health and Safety Executive have worked with us and have advised us that actually we should only report RIDDLEs now, given that we all now know a little bit more about the infection. We should only report them if we can demonstrate that there is a direct link between the work that was being undertaken and contracting the virus. RIDDLEs, as members of the board will know, are those most serious incidents that result in either absence or result in an occupational disease of some nature. They are managed and monitored through the health and safety executive. Internally, they are worked through our health and safety governance structure, so by local teams, then through the divisional leadership structure, through to the strategic occupational health and safety forum, and then through to quality, safety and experience committee. We undertake deep dives and we undertake thematic reviews. We have undertaken a series of thematic reviews across the RIDDLE reports linked to COVID, and have started to pull together another lessons learned matrix, so that again we can cross-check against experience over the next quarter, whether the things that we've put in place to prevent infection have sustained, have endured, and most importantly have been effective. So touching on the RIDDLEs, in terms of the health and safety executive improvement notice, the improvement notice that was issued in relation to Ysbyty Glenclwyd last year has been complied with. That was particularly relevant in terms of the level and nature of training for fit testing, and therefore the application of fit testing to appropriate staff groups. And when I'm saying appropriate staff groups, there are different levels of personal protective equipment, masks that need to be tested. There have also been very, very different supplies of said masks over the period of time. We have fully complied with the improvement notice, which was to effectively retrain and refit test all relevant staff in YGC. We've also we've rolled that out to the other areas as well. We've been piloting most recently, and particularly linked back to a case that we had last year, which surrounded the sad loss of a member of staff. That demonstrated that there were some staff groups that we couldn't necessarily evidence had been fit tested. We could evidence that they were wearing PPE, but we couldn't evidence that they had been fit tested, and they were predominantly night staff. Other groups of staff had been tested on one mask and then were wearing a different mask because of supply. So we piloted over the last month, almost like a little bit like an ID card. So it's clear which mask the individual member of staff has been tested in and trained in terms of donning and doffing, to make absolutely sure that the mask on the card is the mask that the individual is required to wear. This is also quite helpful in terms of staff who are moving or roving between different areas, particularly, for example, our bank or our redeployed staff, because they can only then wear the mask that is on their card, or be booked in to be fitted against a different mask. So there's there's a very comprehensive programme around fit testing in response to the HSE, and the HSE have come back to us and are satisfied that we've met the requirements under the improvement notice, and will continue to work with us moving forward. I hope that's answered the question, but if not, I can cover some more ground.
Lucy?
No, that's helpful. Thanks, Sue. You're right. We have discussed it, Quality, Safety and Experience Committee. I was just conscious that detail that you've just provided wasn't in the report, and I think it provides a lot more confidence now in relation to the response provided. So thanks very much.
And Lucy, picking up the wider is a difficult balance in terms of this annual report. As you know, there have been a number of innovations put in place. The one that Sue has described, I think, is working incredibly well and has also been very well received by staff. As you know, Quality, Safety and Experience Committee recently, and indeed our Executive Management Group, we have had presentations from the YG hospital management team in terms of the lessons that they have learned from their outbreak, and I think that had two effects. It was very challenging for them to do, and I thank them for doing it. It's difficult, but it enabled them to reflect and others to reflect. It's been very well received across the organisation in terms of reflecting the human factors that you've described, the human behavioural issues, acknowledging that people were tired, acknowledging that people, it felt like things were getting better. So acknowledging all of those and the need to keep ourselves be wary and to continue to keep the processes in place. So that was a significant piece of learning that has been shared across the organisation. I do want to come back to the Safe Clean Care programme, because again, that is a vehicle for not only receiving best practice, for embedding best practice, and the PPE, for example, that was something that's been discussed via that group and taken forward. We do have post-infection reviews for every single one of the infections that we have, and they are taken through our infection prevention subgroup, which, as you know, Lucy, as part of the changes in governance, will now be reporting directly into Quality, Safety, Experience in terms of the local lessons learned across all our infections, not just the COVID, to ensure that they are being received across the health board. And that does include input from mental health, dental colleagues, as well as secondary and area care colleagues. So I'm happy to provide more information via QSE, Lucy, so that that you can gain the insurance via there.
Thank you, Jill. Just have one last question, if I may, please. On page 66, it refers to the compliance scores for the national cleaning standards. I noticed that the compliance dipped in December. Do you know why this was and what was done about it, please?
You're on mute, Jill. Sorry.
Apologies. I obviously put the mute button on instead of taking it off, so please forgive me. Throughout the pandemic, we have had some challenges in accessing clinical areas and our ability to undertake effective audit programs. We are working with informatics clinics to ensure that we can capture that in a more real-time basis. I have had confirmation that we are fully established around domestic systems, but we have had problems, as I say, in accessing some of the data. We've had to strengthen our observation and review the programme, and we will continue to do this in light of the continuing healthcare improvement in the cleaning standards. I don't know whether Mark, as a responsibility for estates, wants to come in. But there has been a restriction on decant space, for example, Lucy, to be able to do some of the cleaning.
Yeah, thank you, Jill. There's nothing I can really add to that. Thank you.
We have also, just to complete that, Lucy, we have re-emphasised the requirement around the audits to be undertaken and staff to be released to undertake them, so that we can get the assurance. And as I would reiterate, we've most recently had a conversation with our informatics colleagues about how we can make this simpler and ensure that we are gathering the data in real time. And that is going to be that is a conversation that will continue across a number of areas of safe clean care.
Thank you.
Okay, a couple of observations and a couple of points from me, Jill, if I may. So at the start report, the executive summary, page 4, and I recognise further information is offered, or this is expanded upon later in the report. But I do think there is a risk that you, the team, the organisation, undersells itself and what was achieved in the description of the achievements on that page. I think we all know the scale of the effort that was required to not just deal with the vaccination programme or to just establish a hospital, but we established 3 rainbow hospitals. As the report identifies, there's been no infection issues in those sites, and you all know as well as I do the amount of time, effort, logistics, partnership working went into that. I recognise the steering group was established, but when you consider the efforts that you made, others made, to ensuring that we had an effective supply, particularly during wave 1, that in itself was a considerable undertaking. And then set against that is the performance, for want of a description, you described in terms of a number of key surveillance infections and our comparative performance with other health boards, which I think is also commendable. So I think the board ought to recognise all of that and the wider context, and also the amount of effort that was involved in terms of maintaining all those things, particularly directed towards protecting our staff and also our patients. All of that said, can I then ask a couple of questions? So the first from me is there is reference to increasing the number of staff in the IPC, Infection Prevention Control Team, and we all know that they were challenged during the outbreaks. How content are the executive team that the additional staff that have been put in place there are sufficient to both deal with any future waves, but also to deal with the more routine, for one of our description, infection prevention work? It'd be helpful to get your comment on that. Secondly, confirmation that the mortality reviews that I referred to in this report are, I think as Lucy touched upon, are being used to identify any significant learning, and they are being suitably responded to. And then finally, from me, Jill, on this report, there's a third point for me on page 9, where it says our aim is by December 2021 to have a zero tolerance approach to healthcare associated infections throughout the health board. I know we need to set a target date, but that does seem to me to be a fairly long way off, particularly with the prospect of a third wave coming. So can the board have assurance that that is an indicative target and all is being done to bring that forward as far as possible? Does that make sense, all of that, Jill?
It does, Mark. I will bring Arpan in to talk about the mortality reviews, if I may, but that work is ongoing and it is part of the process of sharing the learning, and we have picked up some of that learning initiative. So I'll bring Arpan in on that in a moment. In terms of, first of all, thank you for recognising the achievements that the teams have achieved over the last 12 months. They have been phenomenal. Has been an extraordinary year that people have had to respond to in a way and a level of pace that we've never seen before. So we have had some really significant achievements. In terms of the infection prevention and control team, the conversations about investing in the IPC team have been ongoing. This is an increase, but I do think that there are two things I would want to pick out. We are working with the universities, for example, to ensure that we've got the staff appropriately trained moving forward, because that is part of the learning some of the lessons and embedding them in training moving forward. So am I ever going to say, Mark, that I've got enough of a team to do IPC? We could always do with more. We are out to advert at the moment for a lead for this service, and I am confident that will make a significant difference once we have it in place alongside these. The critical element of infection prevention, Chairman, is that it's everybody's business. So you ask about the 2021. We have a zero tolerance approach now in terms of we do review every single infection. The point comes back to the point that Lucy raised, that this is human behaviours and we're not going to change human behaviours quickly. It is everybody's business. I can have the biggest IPC team in the world. If it isn't owned and embodied within the organisation, they are still going to have limited impact. So I'm not sure that answers your question. What I'm saying that this is, and it does come back to the stronger together piece that Sue's team are leading on, that this is everybody's business and acknowledging it. So the indicative target is there. I wouldn't like you to think that we're not applying that ambition right here, right now, because we are.
Okay, all right. Thank you. So Arpan?
Thanks very much, Chair. So just to add to what Jill has just said, that the Office of the Medical Director and the Office of the Nurse Director are working really close together to make sure that the review of mortality that has occurred, sadly, because of the pandemic and because of nosocomial infections, contribute to an enhanced learning for the organization. The other thing to note is because of the importance of the subject, there is now an all Wales process that is being determined. And on behalf of the organization, I've attended a number of meetings, which I think will be extremely beneficial in terms of creating a uniform framework for reporting and learning across Wales. So when I know more about how that is crystallized, I will feedback, obviously, through the appropriate mechanisms to colleagues.
Thanks, Arpan. So the final point, Jill, from me is the recovery report refers to the fact that the Health Board has commissioned an independent review of hospital-acquired infections and therefore the learning from the outbreaks. We all recognise, don't we, that that's the important step in terms of ensuring we have an objective assessment of what's occurred, how we've responded, how we've learned, and so on and so forth. It refers to the report probably being available in June, and it informing the action plan. What we all also need to ensure, Jill, I'm sure you are alive to this, is it's reported back to board.
Absolutely, Chairman. If it had been available, it would have been included in the board. But as you know, there was a slight delay in ensuring that we had someone that was completely independent undertake that review, but also with the appropriate qualifications to pose the right challenges across the health board. So this is around the nosocomial outbreaks that we've had. We will be bringing that back to the board and via, I'm sure, QSE once we receive that. I am anticipating that in June. I am in the process of getting a meeting with the report's author to see if there are any early lessons that we need to be taken on board before we receive the full report.
Thank you. Thanks very much, Dr. Nail. So I have no other questions indicated by anybody in the meeting, Jill. So again, we'll move on to 3.3, targeted intervention. Can we do the same? I'm conscious to try and keep us on time as much as I can. We're already running slightly late, and that is, can we take the first item and also the framework virtually as read, and leave you to highlight what you feel you need to highlight in respect of both items, and we'll take them together.
So if you can take them as read, Mark, there's a couple of points I just want to highlight. In terms of sharing the principles of targeted intervention, we have done some engagement on sharing those principles, and that continues to be ongoing. And I know Jo may wish to come in terms of the engagement she's taking place with local authority colleagues. What I would say as well is that the checks and balances we have in place, we have done some indicative scoring within the teams, but that was checked with our IM colleagues, link colleagues, but we've also checked that as far as possible across other parts of the organisation, and we will continue to embed that. Critical to this is us ensuring that where we are moving forward, where we consider we are making improvements, that they are recognised throughout the organisation and with our external partners. I'm conscious, Jo, you've got your hand up, so you may want to come in on that specific issue.
Thanks, Jill. Jo?
Jochen Bauer. Yes, briefly, just to confirm that there's a process of involvement and engagement with our local authority colleagues, either has taken place or is planned to take place over the next couple of weeks and months. Thank you.
So on that basis, Chairman, I will ask each of the leads to give a quick update on where they are against their own individual maturity matrix. The report, the cover sheet itself outlines who the leads are and who the link IMs are. So if I may hand over, I think the first one is mental health.
Thank you.
And that would be Teresa with support from Chris.
Jill.
Thank you very much, Jill. I'm trying to speak in Welsh for this item. First of all, I'd like to thank the buddies, Cheryl Carlisle and Lucy, for their help with the work. Chris and I have been very grateful for the help and comments and the scrutiny that's taken place to help us to bring this matrix together. So this is the first matrix we're discussing today from all of them. I think we've followed quite a similar route to some of our colleagues. We've developed this matrix work from the team at grassroots level, as it wound up, through the operational team, so that it is a reflection of all of our work. You'll see there are three parts to this matrix in mental health. We've got the children, we've got the adults, with Chris leading on children, myself on adults, but we're also making sure that there is a part of the section within this, which is on the transitional period. We know that that is essentially important, and it's somewhere that our teams are working on at the moment so that we can offer the best for our young people as they move from children to adult services. And following discussions with our buddies, we all agreed it was important for us. And we have discussed that with Welsh Government as well. So as far as building this, we did this from all the teams, everybody contributing comments. Chris and I reflected the priorities within our departments where we viewed our challenges to be, and that is where this work has come from. As far as the next steps are concerned, we've explained those, they're all in the paperwork, but I think it's important we recognise that some of the priorities are work that we are doing across the children's teams and adults teams. And of course, there are areas where we need to target within both those teams. Engagement work and communication work, of course, is something we are trying to improve in going forward. And of course, we want to see progress in the work where there are similar things within both teams. So we'll be working on the financial side, and very important for planning to the future and for the transitional period as well. I know that the children in the forthcoming period will be focusing on development work, and they're bringing a team together to make sure that we can meet the requirements imposed by Welsh Governments. And again, the details are there in the paperwork. These have been very important in shaping our priorities and in wondering where we are on this matrix, where we are at the moment, that is. Within the adults team, I know we, again, will be focusing upon structure. That is very important. What opportunities are there for us to work differently and to the future? And with COVID work, of course, we know there are needs out there in the community that will affect the work for years to come. So it's important that we think differently and that we look at preventative work as well. Finally, I'd like to just mention that we are doing work on the concordate crisis work, and we do need to move forward with that work. And in discussions with Councillor Carlyle and Lucy, we have discussed the needs to focus the clinical route, as it were, and that we do have a pathway to reach our crisis requirements. So that does meet our needs. I feel we've built up this matrix from the right place. We're now busily communicating with our teams, so everybody are aware where we are on this journey and what our targets are and how we want to move forward and work differently to the future and work with other areas within this intervention area, which is the leadership and OD. That's very important to us in mental health, both children and adults. I do feel with the score, you'll see in the paperwork that we have given a score of 0 at the moment in these areas, but I would like to say we're not 0 in everything here, neither children nor adults. Good work is taking place every day, but of course there is room for improvement and we recognise that, and it will be a journey for us. So I think I've addressed the various parts. I've addressed where we've reached, and we are working closely with the buddies at the moment. And I've said that we will be meeting often. So before the meetings with Jill, she will be chairing the steering group and discussing this work and making sure that there's an external lens upon the work we do and helping us to move forward. I feel that the discussion with Welsh Government and internally has been very useful in order to strengthen to work together. Maybe I should finish on that point and take questions at the end, Jill, if that helps.
Thank you, Teresa. If we do have a hand up, Chairman, I don't know how you want to handle this. Do you want individual questions at the end of each section, or do you want us to continue?
Let's do it by section, I think. Before Cheryl comes in, I think Linda's got a general point she might want to make. Linda, do you want to come in first?
Sorry. Apologies, Mark. I think probably at the end, if that's okay, because it may cut across Teresa's and Cheryl's discussion.
All right, so we'll come back to that. Yeah. Cheryl.
Thank you very much, Chair. Just really to echo what Teresa has said, and to say how quickly we've managed to pull this together and welcome this very new way of working. It can only benefit our patients. I'm especially keen that we keep that focus on the transition phase, something that hasn't been so strong in the past, and to just emphasise the baseline point. This is where we're starting from, and to recognise the improvement still needed. I also really am pleased with Joe's points about the engagement with our partners. We must listen to our patients and our partners through this, but thanks to all concerned for this, and really look forward to making some great improvements through this matrix. So thank you.
Okay, yeah, Teresa, sorry, Jill, I cut across you. So we're going to the next area, shall we?
Okay.
Yes.
Thank you, Mark. So I think my area is up next, which is strategy, planning and performance. In a similar way to the way in which Teresa has just described, I've been really keen to work on this with the planning and performance teams to start to engender the necessary local ownership of the improvement journey that we're now on. Nikki Callow, who is my IM buddy on this task, and I have continued to discuss the maturity matrix over the last few weeks, and I'm very grateful to her for her support and guidance. We would like to propose a further change to the matrix as set out here, specifically to one of the strategic elements, which is the first section within here, and we'd like to add the development of a medical and health sciences school for North Wales. As evidence of our increasing maturity as an organisation. I think this is a key strategic issue for us. It's been well recognised in a number of different settings. I think the importance has also been recognised by Welsh Government, and it's worth remembering perhaps that the letter de-escalating the health board out of special measures last year also supported us to the next stage of development of a medical and health sciences school, namely the preparation of a business case by this summer, and that work is well underway. So with the support of the board, we would wish to make that change to the matrix, just to add that in, if colleagues are in support. Other than that, I'm happy to take any questions on this matrix. Thank you very much, Sharon.
I think it's a good point, Mark. I don't see well, actually, Nikki's hand's gone up. I'll let Nikki comment, but I can tell you now, I will support the inclusion. Nikki?
Thank you, Chair. I just want to fully support the work that's gone on with regards to this maturity matrix, and very much like Cheryl, I've been really impressed with how the teams have mobilised themselves at such short notice to bring together the information. And I think the methodology is a good one, with a focus on improvement and progression. And I'm fully supportive of the addition of the Interprofessional School of Medicine and Health Sciences to be included in the matrix.
Yeah, deal, Nikki. Okay, Mark. So take that as read then, that we'll adopt that. So thank you. We'll move on. We're on to leadership.
Yeah, so leadership. The leadership domain is all encompassing, and I think cuts across all of the other domains. I think it fundamentally links with virtually every item on the board's agenda today and beyond that. And I think there's something about us making sure that we recognise that the alignment of our people, the behaviours of our people with the values of the organisation and the vision and the key priorities of the organisation are really the only way that we are going to be the best organisation that we can be for the population of North Wales. This links really, really well with the commitment that the board gave last year, which has been supported both tangibly and virtually by Welsh Government, to the Strategic Organisational Development Programme. So Min Indod May Nerth, Stronger Together, in Unity There Is Strength, is very much around us resetting the organisation, resetting the people across the organisation. So the 18,000 plus people that contribute to delivery of our services on a daily basis. I don't really want to go into the detail of it because I could wax lyrical for hours, but working with our link at IM, Linda, and John, but also with other independent member colleagues, Nikki, Lynn, Jackie, etc., to really make sure that we dovetail this work with the Stronger Together route map. We've developed this. We have made some slight changes over recent weeks to reflect some of the feedback and contribution that Linda and colleagues have made, but also really we've done a sense check against our equality and our socio-economic duty to make sure that the language in the matrix really does reflect our commitment to providing services across our communities and particularly promoting equality and the consideration of our socio-economic duty. So there's some additions that we've made over recent weeks, but happy to take any questions at the end. There is clearly a lot of detail, but I think this is very much hearts and minds with the outcomes based on alignment of people across the organisation. Thank you.
Thanks. Linda, did you want to make a comment?
Os ga I ofyn a cwestiwn hefyd a wrach roi?
Yes, I'd just like to ask a question and make some comments in Welsh, please. May I endorse my gratitude to Sue and colleagues for the interesting developments as she has mentioned. It encompasses everything that is important to the Health Board. 2 points that stand out to me is the engagement, and I understand from all the work that Jill and the team have done that there is a communications and engagements program in the pipeline, but I am concerned about it's restricted to stakeholders, which of course are very important, but to reach the target of assurance, I really want to see what steps the team and the steering groups are going to take to engage and consult with patients and staff, of course, as Sue's already referred to, and with people in North Wales in general, because especially in particular areas that are very complex, the process is very complex. So what steps are we taking to explain the process to people in North Wales? That is the difference between this and special measures. And of course, secondly, in moving forward, and I hope we'll be moving forward quickly with the work, Welsh Government, I assume, are going to decide whether we have reached the requirements. But of course, we'll be moving in different areas at a different pace. So how does the steering group foresee it will report back to the board if one area is causing concern during the pace of development? And maybe another area could be moving quicker. It's a little bit technical, Mark, maybe, but I think it's important in starting this process that we have a clear understanding of the process and clear to people in general, beyond those taking part in the discussions in committees and so on. And secondly, how will we respond if the process it isn't moving as smoothly across the particular areas?
Yeah. Sue, do you want to respond?
Yeah, can I just clarify, Linda? Are you talking about the engagement in the strategic OD program and the leadership matrix, or the targeted intervention improvement matrix as a whole? I think you're on mute, sorry.
Okay, sorry. Yes, well, maybe that explains my concerns, that we tend to speak at different levels of engagement. And it is a complex, I'm not saying it isn't, but I think beyond that specific element and the leadership component, there is a broader task, and Jill has referred to this task in the information she has prepared for today's meeting. But has there been discussion with you, between you and the team? In discussing with you and the team, there is an important task at hand here to explain the process beyond the framework in a broader sense, so that people can have a clear understanding of what it is, what makes it different from other work that is taking place, such as the key programme on changing the health board to be more effective. And maybe I was just trying to raise, Sue, that we need to get this clear at the beginning of the process. And it is very clear to the people who are participating in the committee meetings and so on.
Okay, so if I pick up some of the principles that we are applying to the Stronger Together piece, but also they apply across, and I can see Joe and Jill's hands up as well in terms of kind of the wider matrix. So the principle that I will always apply, and we have applied previously, is rather than talking about, in the past it was special measures and now it's targeted intervention. It is really, really important that we describe what we want for the organisation, what is the right thing for the organisation, rather than saying, well, we need to do this because this is in the targeted intervention maturity matrix. So very much owning the work that we have determined we need to do. And a byproduct of that is that we would progress through the maturity matrix and therefore be assessed externally, but very much to describe the work that we've determined that we need to do as ours, and be able to articulate with our staff, our patients, our stakeholders, and most importantly our public, the intention behind what we have set out and the outcomes that we would expect from their point of view. So to describe as many things as what will this mean for you in your day-to-day life. So that's kind of the overarching principle. With Stronger Together, we've been really clear that this is about having a conversation about what matters to individuals and what would help them to do what they do to be the best version of them. I suppose the other thing I would add in as well, which is absolutely critical, is making sure as one of those principles that we design and create the environment for engagement in languages that are appropriate and accessible. So both in terms of not using acronyms and management speak, but also making sure that people can communicate in their first language, that they can communicate in their preferred mode. So sometimes that's in writing, sometimes that's electronic, sometimes that's face-to-face, big group, sometimes it's one-to-one. So they're kind of some of the principles. I'm conscious I haven't answered your direct question, Linda, but I think there are some overarching principles that we've worked through as a team, that we design principles that we need to follow in any type of engagement that we're undertaking. I'll hand over to either Jill or
yeah, so just Joe, can you come in next? And so, having heard what Sue said, I think what would be helpful is an articulation of what the programme means in terms of engagement moving forward and why that is going to be different to what we've had before. But secondly, the considerations that the team are giving to engagement out within the organisation, including reputation management. So can you just cover those two areas, please?
Diolch yn fawr, Mark. Yes, I'm happy to. And I'm also happy just to touch on some of the sort of more technical process pieces. I'll do that second, Linda. I've already talked about the involvement and engagement piece with regard to our local authority partners. And in addition to that, we have an emerging approach outlined with regard to a number of our other partners in provision. And we have already had discussions with our CHC colleagues in developing our maturity matrices and the scores therein. The Welsh Government and the tripartite, that there are partners in terms of Audit Wales and our improvement regulator, Healthcare Inspectorate Wales, have told us to expect to take some time to move across the domains with regard to our improvement journey. And of course, whilst they do make an independent judgment of our progress, the most telling and the most important judges of our progress are the people we're here to serve: patients, families, carers, and of course our staff, many of whom are also our patients, families, and carers. So we do have a process in place with regard to local authorities. We have an emerging process in place with regard to our other partner providers, and we have an established process in place for staff engagement on the particular issues of targeted intervention, targeted improvement. Now, we tend to weave our communication efforts with our staff into our more general communication opportunities because we do want to make sure the work that we're doing with regard to our maturity matrices is part of our business as usual. Our collective matrices designed to improve our collective services and to implement our collective vision. We're also minded to think about how, as an organisation, we wish to consider our patient and public engagement, involvement and co-design work. And we have a small group, a task and finish group, which is at the moment working through best practice and undertaking a piece of analysis around the engagement, involvement and co-design work that we already do. And it is our intention to present that work at our board workshop on the 3rd of June. Diolch yn fawr, Linda.
Okay, Jill, did you still want to come in?
I'm happy to pick it up in the rest, because clearly the next part is around engagement. So I think things have been picked up by Joe. So if I can continue on the basis of the engagement piece.
You can. Thank you.
Thank you, because that might be easier. So in answer to some of the points made, I won't go through the document and I won't repeat what colleagues have said. This has been a really interesting conversation in terms of actually challenging ourselves, what our perceptions were in terms of engagement across a number of different areas. And we have looked at this in terms of our partners, our publics, our patients and our staff. So we've cut this across all areas, and hopefully, Linda, that will start to address some of the points that you were raising. I'd also like to say this is another cross-cutting piece of work. So engagement and communication is a key element of the targeted intervention framework, and indeed our matrices. And it's something we've recognised as a group, and recognise that we need to come across and do some checks and balances. So what is influencing leadership or engagement, perhaps in mental health, that perhaps we need to reflect in the engagement piece. So those individual conversations are taking place. I think the point that Linda made is very well made, in that part of the conversation we had is, do we really hear and listen to people? Or are we engaging as fully as we could be? And that was the test we gave ourselves. And indeed, our link IMs challenged back to us as well, in terms of, are we engaging with all of our staff or parts of our staff, all of our public, some of our public, all of our stakeholders, etc. And consequently, we did feel that we had a way to go. We had some excellent practice that we need to build upon. Some of that is being developed with colleagues, for example, in our community health councils, in terms of developing the safe space events, which I know are taking place in mental health, but equally they're not happening everywhere. It is a core part of the philosophy of developing the clinical strategy, and also ensuring that our clinical leaders and other leaders across the organisation are continue to drive the messages across. So we have again, and I want to thank both Ivan and Jackie in terms of the challenge they've given back to us, to consider whether we are addressing all those areas equitably across the piece. We are doing some stakeholder mapping. Sorry, Linda, that does include the public, because they are a key stakeholder. They are the key stakeholder in terms of access to our service. And absolutely, as Joe's described, where can we learn around good practice, around not just engagement co-design of our services, so we're actually reflecting the conversations and the input from that wider engagement group. So we have again tested ourselves quite hard. We have as a group considered that we need to come together as to understand where those cross-cutting elements are in place and how we need to address those. I think the point that Linda's made around the messages around targeted intervention and what it means and how we're approaching it across the wider public, we need to consider as part of not just the engagement piece, but the wider targeted intervention and how we deliver these messages and test our own thoughts against those of the public that we serve and the citizens that we serve.
Okay, thanks, Jill. So I've got one comment, and that is that I spoke to the NHS Chief Executive last week about a variety of things, Andrew Goodall, but one of the things he did comment on positively was the targeted intervention meeting that was held on the 7th of May between the executive team and the Welsh Government team, and the endorsement of the approach being taken by the board, particularly led by the executive team, which was good to hear. So without further ado, can I take you to the recommendations? So the board is asked to note the progress to date, to agree the matrices, to agree the initial baselining in terms of the scores for each matrix, agree the targeted intervention improvement steering group terms of reference. Are members content to do those four things?
Yes.
Yes.
Okay, deal. Joe, Jill, I would suggest the next thing that needs to happen, if it's not already happened, now that these have been cleared by board, is they need to be shared with the tripartite government's arrangements. So not just Welsh Government, but also Audit Wales and so on and so forth. Will you pick that up?
Yes, we will. Diolch yn fawr.
Okay, thank you. Right, so I'm going to move us on again. So we are on to item 3.pedwar, which is the chair's assurance reports, which have been circulated, which can be taken as read, I think. But I'm going to take them one by one in case the individual chairs want to highlight any particular issues. And I will start, if I may, with you, Medwin.
Thank you, Mark. I propose that you accept the paper as presented. I just want to draw your attention, however, to two items. Internal audit's ability to deliver their plan, depends on the audit team's ability to get out and test, which may be inhibited, of course, by the pandemic restrictions. And the other point to note, I think, is the limited assurance report on the mental health and learning disabilities governance arrangements, namely the implementation of the Together for Mental Health, and secondly, the concerns around psychological therapies and the services in terms of the outward reporting and leadership. And it was pleasing to note that at our meeting on the 18th of March, that the Chief Executive was in attendance. And thank you, Joe, for your attendance. I think it's vitally important that the Chief Executive does attend audit committee meetings. And there was concern about the pace of rollout regarding the implementation of the Together for Mental Health strategy. And I think that Jo took those on board, and from her opening report to this committee today, she referred to that. So thank you for taking that on board, Jo. But I just wanted to highlight those two areas. Otherwise, I propose that you take the paper as presented. Thank you.
Thank you. So, Lucy, do you want to comment on mental health and the work being done around the partnership group, etc.?
Yes, thank you, Chair. Yes, the division has recognised that the Together for Mental Health strategy that was in place before, it needs drastic review. That process has already been started. There have been a number of meetings taken place with a new group of stakeholders, including service users. And that will become a standing agenda item. The delivery against that strategy will become a standing agenda item on the Together for Mental Health Partnership Board. We're still in the early stages of reforming that group, however. We want to take the time to make sure that it's right, that the terms of reference has been thoroughly reviewed and we've got the right people around the table. It was very disappointing to hear the limited assurance result from the governance review. But I am confident with the renewed leadership within the division that these will indeed be addressed, and we'll keep an eye on that as well.
Okay, thanks, Lucy. Medwin, I think we also need to note the schedule of approved claims, which is included as a link in your assurance report. And I'll just confirm that members are happy to do that. I am. Our colleagues happy to do it.
Yeah.
And secondly, I think you want us to note, Medwin, that the risk management strategy and policy remain extant pending the annual review, June, July.
Yes.
So we hereby note that and endorse it. So thank you. If you're happy, Medwin, I'll move on then.
Yeah, certainly.
Okay. Lucy, QSC, and do you want to cover the main meeting headlines as well, please?
Yes, thank you, Chair. There's nothing in particular I want to call out in relation to the March meeting, other than the May meeting, which we met on the 4th of May. And as Jill has already referred to, the hospital management team for Ysbyty Gwynedd presented to the committee on the outbreak that they have been experiencing there. Whilst numbers have reduced considerably, and they've reduced over a shorter period of time than the previous outbreaks, which obviously is positive, it was acknowledged that learning from the outbreaks on other sites had not been fully embedded across Ysbyty Gwynedd. Jill's already referred to the external review, which will be coming to committee. The essential point then is that we need to make sure that the learning is indeed embedded. And focusing on the behavioural aspects as we referred to when we discussed the Infection Prevention and Control annual report. The May committee also received the vascular report from the Royal College in private session because we were still in PERDA. So we weren't able, unfortunately, to discuss it in public session. And I won't go into any more detail on that because that's actually on the agenda for discussion today. Thanks.
Sorry, I haven't promised my device. Okay, thanks, Lucy. I don't see any hands raised, so we'll move on. We'll move on to Finance and Performance Committee, FBC. The first was when I was chair, and I have no points to highlight. The second was with John as chair, and I'm grateful for John to taking over the chair position on that committee. John, anything you want to highlight?
Thanks, Mark. Yeah, just a couple of points to highlight. One's a couple of positives in terms of, and I'm sure Sue's going to cover this with the finance report later on, but the fact that we were able to declare a very small surplus for the first time, I think was a real positive. And the second, the performance on savings was much better than expected compared, given the impacts of COVID, and is significantly better than other health boards around Wales. I think the one negative from a real risk and concern point of view is just the extension of the waiting lists and the likely time frame for us to recover, which is perceived at around 3 years, but maybe longer. That's something obviously there's going to be a lot of attention on, but no, that's the long-term concern in terms of the services we deliver to patients.
Thank you. Thanks, John. So, Jackie, Charitable Funds Committee, anything you want to highlight?
Thanks, Mark. No, there's nothing additional to what's written in the report. Thank you.
The ethical investment point, Jackie, is proceeding, because we have discussed that, haven't we?
It is, yes. We're still doing some work with Brew and Dolphin around making sure that what comes forward for board is the right document.
Okay, Pierre. Lucy, Mental Health Act Committee.
Thank you. Nothing further I'd like to highlight.
Okay, Remuneration Committee is mine, and there is nothing I wish to highlight. Happy to take any questions, but no, I wish to highlight. Lynn, Strategic Partnerships Population Health Committee.
Thank you, Chair. I would just like to highlight one particular report we received on Stronger Together. This is, as been mentioned throughout the meeting, so far, it will be a fundamental part of our going forward on communication, staff attitudes, staff surveys. And the reason I mentioned this word staff surveys, that we did have the staff survey results reported to us, but it was difficult to actually ascertain because whether it was improvements or decline, because it was not comparable with previous ones. So one of the questions we asked that we like to be escalated is to whether or not the board would like to see those staff survey results, or whether you'd like us to hold off and incorporate it into this Working Stronger Together.
So I personally think, as chair, it ought to come to board, because at the very least, it should signal to our staff, the workforce, that we've got a keen interest in what they're saying, and we wish to ensure that appropriate response is taking place. I don't know if Sue's got any comment, but that would be my preference.
That's fine, Mark. I think so. The committee were asking the question because it was a very limited survey. It was done in autumn 20, but absolutely fine. We can bring the report to board and describe the action that's been taken as a result.
Thank you. There is one other point that emerges from indirectly from the notes of the meeting, but also has come up in a meeting I had with Nikki last week, Sue, and that was an ongoing conversation, I think, around how the Stronger Together program is going to be evaluated.
Yes, so we're hoping to identify an academic link that can work with us to aid to guide us, so that we could potentially use the program as a piece of research and potentially publish, but also to really think about how do we build in a really strong evidence base into the work moving forward. So we've been working to try and identify a suitable academic link. We're continuing to try to move on that, particularly given the length of time that the route map is going to move over. That's been a little bit of a challenge.
Okay, thank you. Nikki, Lynn, anything you wanted to add?
No, I haven't.
No, that's fine.
Okay, thanks. Thanks, Sue. So we'll move on again to digital. John, anything from you?
Not much other than the digital strategies later on in the agenda, which I would thoroughly recommend. The real risks are around national systems, but I think everybody's looking forward to an improved working relationship with the new national organisation, Digital Healthcare Wales, and hopefully that will progress in a better way to help us actually achieve the key systems that will enable transformation in the organisation.
Thank you, John. So we'll move on again. Stakeholder reference group. Francon is not here, having now left us. As an aside, I understand the election is ongoing to identify a chair of that group. But the highlight report, assurance report, is here for everyone's information. We'll move on to the Healthcare Professionals Forum. Anything, Gareth, you want to highlight?
Thank you, Mark. No, nothing that requires escalation. I would just draw attention really to the first bullet point under our summary of information, which was around the targeted intervention improvement framework. We were, I think, an early stopping point for the discussion and development of that framework. And I would just confirm really that I'm pleased to have seen the feedback that the forum members gave the team that day has found its way into that framework, in particular around the engagement domain. So pleased that the interest the forum had in that framework has allowed the framework to develop in that way.
Thank you, Gareth. And then finally, we have the Local Partnerships Forum. Sue.
Thanks, Mark. So I've got nothing significant to draw out other than, as this was the last meeting of 2021, to record thanks to our trade union partners for the massive amount of support that they've provided to us, working with us over the COVID pandemic. So I just think it will be helpful to record our thanks to trade union partners, continued engagement in a very, very proactive partnership relationship. Thank you.
Okay. So there was a point in feedback for the board that pricked my interest, and that was the members feel there's a lack of broad managerial representation at the meetings. Could you help me understand what that relates to?
Yeah, so in previous times, the membership has extended to area directors, etc. I think as part of the pandemic, that has been more of a challenge. Pleased to say that the attendance at the April meeting was improved. So, for example, we had mental health division were represented, as were some of the areas. We just need to work through with some of our other colleagues, because I'm not entirely sure that they were all clear that they were members and therefore required to attend, but that is in progress.
Yeah. So Adrian wants to come in.
Diolch, Mark. Thank you. Can I just go back to the Health Professionals Forum, please? Just some intervention. Could we just? I'm sorry. Could we just record the Health Board's thanks to Prof. Michael Rees? Prof. Rees' tenure as secondary and tertiary care medical representative ended on the 2nd of May. He's had significant input into the forum for 8 years, not only as the representative of secondary and tertiary care, but he also had 10 years as chair and vice chair. And his commitment and dedication, I think, has been valued by all of us. So we could just record our thanks to Prof. Rees. That'd be really, really great. Thank you.
Okay, thank you. Well highlighted, Adrian, and we will do that. Thank you. So, John, you've got your hand up, I think.
Yes, it was about HPF, but I can ask it later if you want, or ask it offline.
No, go and do it now. You've got the mic. So
okay. Well, it was for Sue, because I picked up on the repeated recommendation around OD, and I just wondered for Sue how your engagement with HPF in terms of their recommendations for the strategic OD program.
Okay, thanks, John. So I actually had a meeting with colleagues from HPF week before last around some specific issues, particularly around recruitment. but we've also made sure that we've got representation in our tactical and delivery groups as part of the infrastructure for Strong Together, and I am attending the next HBF meeting, and we'll be going through the route map and the process that we are going to be following.
All right, thank you.
Okay, thanks, Sue. So we'll stop that item there then, and we are now at comfort break time, albeit a tad late. So I suggest we have a break now and return at 11:45, please.
You're on mute, Mark.
Thank you. Thanks, Lucy. Okay, it is now 11:45, so we will recommence. And we are on the operational plan item. Mark, over to you.
Yeah, thank you very much, Mark. So this is the end of the year report that shows where we got to in terms of achieving the commitments we set out in our plan for Q3, Q4, so for the last 6 months of 2021. This report has been approved by the executive team, and it's since also been reviewed and supported by the Finance and Performance Committee. I think just one other point I want to add before I open it up to questions is to say that the SPPH committee received a report at their last meeting setting out whether and how actions that we hadn't achieved last year have been carried forward into the 21-22 plan. So we completed that reconciliation and we shared it with SPPH committee. I'm happy to take any questions on the report, Mark.
Okay, before I open it up, Mark, Lucy and I had a conversation with Joe last night on the back of something else, where we raised a couple of issues around process and points of accuracy, which Joe may not, I don't know, been able to speak to you about yet. Joe, do you want to respond both?
Just to remind our board colleagues that we have started a process of reviewing the performance reports that we intend to bring to subcommittees and to board as a part of our assurance and accountability obligations. And part of that process will look not only at the range and content of performance reporting, but will also look to strengthen the processes associated with gleaning the information from our frontline colleagues. And with regard to that, we are constantly working to improve our processes to make sure the information we provide to board colleagues is as clear and as complete as possible. And an example of that is seeking to improve the involvement and engagement of colleagues with particular regard to the aspects included in the report associated with mental health. And that's an ongoing process of improvement which will run alongside the review and repurposing of our performance reporting to subcommittees and board. Diolch yn fawr.
Okay, thank you. So I'm going to go to John first because he chairs F&P and they've received it before board. John.
Thanks, Mark. Just a couple of questions or observations, really. One's a general one, which is a number of projects have had dramatic changes as we got to the end of the year, going from green to red or red to delivered. And I was just thinking about future reporting. Would it be helpful to have more clarity on progress, such as a percentage complete? That way we get assurance of movement of progress month to month, or as we get towards the end of the year, how close we are to completion to get a bit more understanding of how well we're doing. The second question then is on page 10. There's reference to the virtual outpatient appointments. And it's saying we had a decline in use of the virtual, driven by the limited pilot. But for me, a pilot is something you do, you stop, you review before you then move on to something else. And what I was wondering was, what were the conclusions at the end of that pilot? And then the final question is the next one, the 4.3. Is there punctuation missing or a piece of text missing? Because the sentence doesn't read quite right to me. So where it says clinical services strategy plan, is there something missing there?
Okay, if I can pick up those, if I may, Chairman. So the first about moving from green to red or from red to red to to deliver the sudden change. I think there are some that can be binary. You know, the completion of a business case, for example, I think can move from 1 month to the next. There are others where that may be a source of more kind of question or concern from all of us. So I think that is something we can look at, John, perhaps informed by consideration of the specific examples. But I am aware there are a small number that did move in the way that you've said. On the one on action 3, so I think we're looking at page 10 of the report. I'll ask Jill if she wants to come in, but my sense of this one is that this relates to attend anywhere. And the comment there saying that we have seen a decline in the use of virtual clinics due to the limited support and ability to roll out Attend Anywhere within the last few months. And as part of our new service investments for 21-22, we have now committed to recurrent funding of Attend Anywhere, and we continue to monitor the uptake of it on a weekly basis. But we are expecting to see an increased use of Attend Anywhere going forward. So that's my explanation on that one specifically. Jill, I don't know if you'd wish to add anything else on that point.
No, I think you've covered it, Mark. In terms of some of the decline around the Attend Anywhere was a lack of a concern that it wasn't going to be available for the future, so that investment wouldn't be there. Clearly, we've had some investment to move forward on this. There will be inevitably, I'm sure, requirement for further review of that investment in line with the rollout. But Mark's right, we are now looking at monitoring the progress against our trajectories for Attend Anywhere, and indeed the wider systems that are available to us to connect with patients and other healthcare providers.
And then on your final question, John, yes, my apologies, the English there is not as clear as it could be. I think for some time we talked about a digitally enabled clinical services strategy, and there was an element of confusion about whether that was going to be a combined clinical services strategy and the digital strategy, or how we're really proceeding with those two separate elements. So I think what we could have expressed more clearly here is that we now have a separate digital services strategy. That's obviously on the meeting later on today. Clearly, that crucially needs to respond to our emerging clinical services plan. But to be clear that we are planning to work on a separate clinical services strategy, a separate digital strategy here today for the board. But our first piece of work, and this will be set out very clearly in the plan for 21-22, is a proposed refresh of our overarching strategy, living healthier, staying well. But I think that commentary could have been a little bit clearer on that point. That's the point we're trying to get across. Thank you very much.
All right, thanks, Mark and Jill. Just to come back on the virtual outpatient bit, my point was around it being described as a pilot. And for me, any pilot is a limited time frame. You stop and then you assess things before you make commitments to doing anything else. So I suppose my concern is we're describing something as a pilot, but in reality, this isn't a pilot. This was a soft launch or a limited implementation, and it may seem semantics, but it's important because from an assurance point of view, a pilot will give us clarity about, well, we've done an assessment, it is the right thing to do. And that's where I was coming from in terms of that question.
Thank you, John. And I think it's a point well made. We did pilot it in certain areas, but it has moved on from there. So we'll clarify the language moving forward. It is being taken forward in those services where it's going to see the most benefit.
All right, thank you.
Okay, thanks. And on the broader point about approach to monitoring, we'll come back to that, I feel, at the end of the meeting in terms of on this session. So, Lucy, do you want to come in next?
Thank you, Chair. So the objective of this report is to provide us with an update on progress against the key actions identified in the annual plan. However, when I read through this report, it doesn't do that. I can't take assurance regarding either the progress or closure of key actions contained within the report. So as an example, the development of a digital health record is reported in this paper as completed. So to anyone reading this, any member of the public or any of our stakeholders, they would be left with the impression that the Health Board has now developed a digital health record, which isn't the case. The reference to implementation of a digital dictation project, it was reported red in December and January, green in February, and then red again in March, which I believe is inaccurate. There are a number of other examples which I have highlighted to you, which I won't go into now. But as you know, I have repeatedly raised concerns about the content of this report and the lack of transparency in reporting of progress against the plan. Now, I absolutely acknowledge, that the review that's taking place to revise the format of this report and to address, to make sure it's more robust in future. But I have been raising these issues now for over a year, and this is the year-end report that should be giving us an accurate and up-to-date position in relation to some of those. And it's just unacceptable that this hasn't been addressed and that this report in its current form, I just can't rely on.
So through you, Chair, if I may, just to say a little bit, to explain a little bit about the Q3, Q4 plan and what we set out when we approved the plan as a board last October. And I will use the example of the digital health record. I do take Lucy's point about the use of language and around, we will have implemented digital health record. I do accept that. But when we looked at the plan last October as a board, we set out both actions and outputs. And as an action, we said we were implementing a digital health record because that's what we're doing. We've approved a business case, and that is indeed work that is underway. But we also set out the outputs from that action in this period. What were we actually setting out to achieve within the broader context of the implementation of a digital health record? And on this one specifically, the outputs were intended to be that the project would be mobilised, by which I take to mean staff were being appointed and we are proceeding to implementation, etc. So I suppose it's important to be clear that we've scored it on whether we have achieved the expected output within that period, not necessarily the overarching, implementation of the digital health record. So I think I want to agree with you, Lucy, in terms of the language used in the plan. But I just wanted to clarify that distinction between, the broader, longer term action, if you will, and the specific outputs that we expected in any given period. And I am content that we've scored it in a way which is consistent with what we advised the board we would do last October. Now, I think that's the general explanation, and I think that applies to a number of the points that you've raised with us. But as both those two are within the digital space, I should perhaps give Chris the opportunity to comment if he wishes to add anything on those two, specifically the digital health record and the digital dictation.
So I don't think that's ready. I think we need to resolve a couple of things here, Mark. So the first is, and thank you for the explanation, but it's in your interest, the Chief Executive's interest, the board's interest to seek to get this conversation once and for all resolved. And I know there's further work going on, but I'm with Lucy in the sense of, so if you take this report at face value, Mark, of course, the headline, if you like, action, given there are a variety of milestones to that action, would suggest, as Lucy has said, anybody reading this from the outside would think the whole thing must have been completed because that's how it's been graded in this report. And I think there needs to be a clearer description, Mark, if you like, as to what has been completed within that overall intention, because at the moment what we are faced with having to interpret what's in the report and arrive at an assessment of whether it's been completed or not based on not the full picture. So I think, Mark, we've got to address that point. The second thing is, and this is my plea to the team, not just to you, Mark, because you and your team pulled this together. But if you take the mental health section, and I bring Teresa in now, I would say it's pretty clear that the descriptions in the mental health section are actually not where we are. And I do think there is a process point around, we should be confident as a board that individual executives have taken a view on their section of this report, Mark, and they are signalling that they are content with the accuracy of the information being conveyed. And at the moment, I don't think we've got the process in place to ensure that. You may have a different view, but before you offer a view, if we bring Teresa in to talk about the mental health section, I think it might uncover what we need to do, if that helps. Teresa.
Diolch Cadeirydd a Mark.
Thank you, Chair and Mark, and thank you for the warning. I went about researching what had happened, and I can say that I'm signing off as the Executive Director on matters around mental health. In mental health, we have a bit to do to make scrutiny work. So we need to work with my team to make sure we strengthen the system for that point of view. The team is scrutinizing the information, and the information is going to the senior department that we have. But obviously there's a problem here with interpreting where we've arrived. I agree with you, there is good work taking place with all these actions, and we had green showing in December, January, February, for example, with doctors and primary care. So we're on track, but I think that purple colour at the end maybe is to overstate it, and that might reflect the fact that we were on the right track. But of course, we haven't completed that work with our doctors, and we haven't completed the work, certainly in terms of the clusters. So I think that we do have a problem in terms of interpretation, and we need to work with the team to make sure that the actions are more smart, as it were, that they are more robust and clear at the beginning. That would help our team and Mark's team to be clear with you and to be clear with the public where we're at. And I know we have got a problem with interpretation. I hear what you and Lucy are saying. How have we all finished the work? Well, no, we're starting the journey. So that's an example. With interpretation, it wasn't clear to the team what they needed to do, but I can amend that for next year and hopefully working on a more robust system with Mark. And I'm sure we can strengthen things for the future and have the required system in place. Thank you, Chair, and I apologise to you, Lucy, if there's been any misunderstanding.
So I think, Mark, then what we need is an assurance from you and Joe that this is going to be resolved before next time, both in terms of the description and the depiction of progress against the true description of what we were seeking to achieve for the relevant period. But also we need confidence in the fact, don't we, that, and as I highlighted, Mark, I recognise this isn't just rest with you and your team, but there are effective processes in place within the executive team and the organisation to ensure that someone, i.e. the lead exec or whoever you identify, is signing on the report of progress that's depicted in the report. And I think we have now got to resolve that once and for all.
Okay.
Joe?
I agree, Mark. Mark and I will ensure that process is put in place with immediate effect.
Okay. Lucy, has that satisfied your observations for the moment?
Well, it's disappointing, Chair, that I've been saying the same things for the last year. So I would very much appreciate this to be addressed as a matter of urgency, because we need to be very clear. We shouldn't have to interpret the report. It should be absolutely clear what we are doing and where we are at in the process. But I appreciate the commitment to address it.
Okay. I agree, and I'm sure that Joe and Mark have noted your observation. Thank you. Medwin.
Thank you, Chair. It's on a similar theme, actually, and John mentioned it earlier. The point of assurance that this paper gives us, given that it's a RAG rating, the number of lines that have gone from red to purple, green to red, 13.7, 18.10, 18.7, and 20.8 from green to red, which is what I want to basically focus on now, which is the medical school. Basically, the business case for that was on track 4 weeks before it went off track completely. We were assured in the Matrix Targeted Intervention Strategy presentation from Mark that this was now well underway, but that's not what you're seeing in the RAG rating on 20.8. It's off track completely there, but the narrative suggests it's on track. So I'm slightly confused as to where we are with that now. Perhaps we could get some explanation. I realize this is the end of March and we're now sort of end of May. Things may have changed, but the RAG rating there doesn't match the narrative and doesn't match what you mentioned earlier when you addressed the targeted intervention matrix. If you can have some explanation, thanks.
Mark?
Yeah, so I can shed some light on that, and I'll ask Arpan if he wishes to comment as well. When we signed off the plan for Q3, Q4, we did that in mid-October as a board, and at that stage, where our plan commitment was to produce a business case by the end of March. I think shortly after that, about November or December, the timescales for the completion of the business case moved in discussion and agreement with Welsh Government, and we're now working to a timescale of July for the completion of the business case. So scored against the commitment that we set out in the Q3, Q4 plan, I think it's rightly rated as red because we had been targeting end of June. We're now working to July, and in that context, we have reported in a sense that the work is progressing. So that's my sense of that as the exec kind of overseer of the report, if you like. But in terms of a detailed owner, I'll perhaps ask Arpan if he wishes to add anything else on that. Thank you.
My point is that the narrative has superseded the RAG rating. That's the point I'm making.
Sorry, can you say that again, Medwin? Sorry, the narrative has
superseded the RAG rating. That's the point I'm making. The narrative is telling me one thing, but the RAG rating is telling me something else.
Right, okay.
And the other thing, in terms of the RAG rating generally, when we look at this, and I realise that Joe has mentioned it at the beginning, that we're going to review the whole system. If something is rated red, there will be a narrative to explain as to why it's gone into the red. I think if there are extreme measures that something goes to the red, to the purple, you could argue that we probably need a narrative for that as well as to how we've achieved that. And if it's a positive learning from it, that the whole system should actually be a learning document as well as a sort of a monitoring tool. Thanks.
Okay, so I think no matter what, Mark, Joe, we are now going over the same concerns to a degree, and we've got to resolve them by the next meeting. We can't be back here again. We got an opportunity as we move into a new planning year and reporting on the new plan to absolutely do that, Mark. And I'd like to think too that the investment we made in trying to get clarity around the actions to be pursued this year will assist. But we don't want to be back here, do we? Any of us. So can we avoid being back here? And if that entails, Mark, when we have the discussion around the next performance report, you, I, Joe, Lucy, whomever, having this conversation around this document again before we get back to board, then that's what we need to do.
Yeah, and I agree with you, Mark, that it actually starts with having a robust plan with smart actions that we're all clear about. That's the it's to the extent that we haven't done that we end up with these types of conversations, I think.
Yeah, it is. Yeah, we will not be back here again. Okay, thanks, Mark. I'm going to move us on, and we have noted that report. We'll move on to the performance report, Mark.
Okay, thank you very much. So this is the end of year performance report. It's been discussed by Finance and Performance and Quality and Safety at their recent meetings. I'm not going to say anything on those topics which are covered elsewhere on the agenda. So COVID, planned care, etc. are covered elsewhere in our meeting today. I do just want to highlight performance on mental health, where we're seeing improved performance against some of the adult mental health measures, less progress being made around CAMS and also around neurodevelopment, and we see both those two areas featuring strongly in our plans for investment and our 21-22 plans. Unscheduled care, we're seeing continued pressures, and although this report talks about the position up to the end of March, we're seeing those pressures continue up onto the present period. We were discussing this at the executive team yesterday. We are seeing increased attendances now across our emergency departments and minor injury units, and that is causing less strong compliance with the 4-hour target, increase in long waits, and also increase in ambulance handover delays. So I think that is worth highlighting. I will just highlight one other point to say that we've seen a positive trend in staff sickness over the last few months, and our staff sickness rates is one of the best across Wales. So with that brief introduction, Mark, I'm happy to take any questions in association with my fellow execs. Thank you very much.
Okay, again, I'm going to come to you, John, first, if I may, as Chair of Finance Performance Committee. Is there anything you wanted to add, John, in terms of your scrutiny at that committee before I open it up?
I'm trying to click the button and it's not working. Nothing to add, Mark, sorry. Yeah, we went through the report. There's nothing other than the things that Mark's referred to that we're dealing with later on. I don't think there's anything specific extra I'd want to pick up.
Okay, thanks, John. Lucy, you got your hand up.
Yes, thank you, Chair. In the executive summary on page 4, it refers to the performance against CAMS, which we can see the graphs on page 47 and 48. And as you've just alluded to, Mark, unfortunately, we're not seeing the same level of improvement as we are in adult mental health. But the executive summary refers to recovery actions being described on page 28, but there's nothing on page 28 in relation to any. In fact, I haven't found any recovery actions specific to CAMS within the report. Are there pages missing?
Okay, I need to check that, but that at face value does appear to be an error in the report, Lucy, so please accept my apologies. I will look into that and I will let you know.
Thank you.
Okay, Cheryl.
Thank you, Chair. Following on from Lucy's point, could we ask that this is circulated to the missing parts are circulated to everyone relevant as soon as possible, please? Not a good omission. Thank you.
Okay, Mark, you've already committed to pick that up. Can you pick that up for me, please?
Yeah.
And circulate when you have.
Yeah.
Okay, I just wanted to touch upon a couple of things, if I may. The first is planned care, which receives quite a bit of attention, understandably, in this report. And to say that, Jill, we are due to discuss the response to planned care at the board workshop, aren't we?
Unscheduled care and planned care.
Okay. So did you want to just touch on briefly either of those and the response? Because there is a lot of work going on, isn't there, both around planned care and unscheduled care?
Happy to, Chair. If I may take unscheduled care first.
Yeah.
So we are working with Welsh Government colleagues to devise an improvement plan across unscheduled care, which is a whole system approach to unscheduled care. So very much involving our primary care colleagues as well as local authority and ambulance colleagues, all of whom clearly have a role to play in unscheduled care. That template of that plan is being developed, will be shared at the workshop, and we are currently have expressions of interest for a clinical lead to drive that pathway, and I'm hopeful to be able to appoint to that and subsequent support over the coming weeks, and there will be funding support for that. I think that's a real step change in the way that we are approaching this, and we are seeing some really good interest in being involved in that programme. And even today, colleagues from Welsh Government are and our own teams are sharing what that plan might look like, taking feedback across the whole of the health board with clinicians, managers, and others. So I think that's a really positive piece of work that we are bringing back to the workshop. On planned care, you'll see that there is a conversation later in the on the board regarding the approach formally to DTC, but also to moving forward in pulling back some of the long waiters that we've accrued as a consequence of COVID. But let's also remember we had a number of long waiters before COVID. We have had some funding made available to us from Welsh Government, which is targeted at this specific area, and we are applying that funding as we speak to ensure that we can move forward to reducing some of those backlogs. So there's two elements to this, Mark. One of them is the short term. How do we start to increase our capacity for planned care? And I use that across the piece. So that might be outpatients as well as diagnostics, as well as operations. So consequently, there is a number of initiatives that are taking place, including access to contracts out with the health board. Equally, there is some strategic work being undertaken to ensure we learn the lessons of COVID, and wherever possible that we separate elective, and again I use that in that broadest sense, from unscheduled care moving forward. And when we are discussing both of those, unscheduled and planned care, we acknowledge there is a clear read across, and we're calling that out.
Yeah, okay.
We have started, as I alluded to earlier, we have started our planned care recovery already, and we are booking planned care patients into both our outpatient, inpatient and diagnostics. I would call out, and I know Adrian is on the call, that we have managed to maintain our cancer services quite well throughout the pandemic, but we are absolutely acutely aware that there are patients that may not have presented during the pandemic, so we may see an increase in demand in that area. Or anticipating, I should say, not may see, we are anticipating an increase in demand in that area.
Okay, and there are a number of actions or ongoing responses that are listed in the cancer section, which are all important to note. Aren't they? Okay, Adrian, thanks, Jill.
Thank you, Joe. I was just going to say that we certainly did see an increase in the number of USC referrals, urgent suspected cancer referrals received in March, going to almost 1,000 above our pre-COVID levels. So, I mean, it's good to see that the patients are going to see their GPs and are presenting now. I think there's been a lot of work and a lot of publicity around this in different areas, but to encourage that as well. And we are, as Jill says, we have managed to maintain cancer services as part of our essential services at a very good level during COVID. And diagnostics, as you know, is returning, and radiology certainly has fallen again in the latest figures, which is the number of patients over 8 weeks is reduced significantly. So that's they're making good progress. Thank you.
Yeah. Mark, Joe, an observation from me to your good selves is that there are a number of instances in this report and indeed in the plan where the risks and potential barriers that are highlighted relate to informatics and capacity, funding including capital, workforce and estates. And I recognise that they are key enablers. They're bound to arise, but there does need to be some sort of sense, I think, at a strategic level as to whether the capacity exists in those areas to respond to the things detailed in this report and in the plan. Now, I know we're talking about digital strategy later, but that identifies other things that might have capacity demands as well. So it'd be helpful to know that either that assessment is taking place or is certainly being considered by the executive team moving forward, given those 3 areas feature a lot.
So Mark, IT, estate capacity, what was the third one, please?
Workforce.
Workforce, right, okay, yeah. So one of the key aspects of feedback that all health boards have had on their draft plans was the need to ensure triangulation between finance, workforce and service planning. So I think as we approach the Q1 refresh at the end of June, looking at workforce is going to be a key aspect for us. I can see that Jo wants to comment, so I'll ask Jo if she wants to come in.
Okay, before she's done, I think a key one in Mark is looking at this informatics. Yeah, there are operational areas are repeatedly saying they need informatics support and systems to deliver the aspirations and actions they've described. I don't know whether at a strategic level, informatics or Chris or the executive team are actually seeking to draw all those things together and work out where the priorities lie and where the capacity matches the priorities.
So we've got investment in IT proposed as part of the additional monies we received as part of organisational capacity and capability around analytics, which I think does in part recognise that. But I'll ask Jo if she wants to comment.
Hey, Jo.
Mark, just to confirm that we are due a refresh of our workforce strategy during this year. I think I'm right in saying that. Perhaps Sue could confirm, and that does give us an opportunity to make sure that we are developing and growing our workshop in line with the service needs that are identified not only as part of our COVID-19 response, but more generally. In fact, in the detail behind our planning process, we are required by Welsh Government, and we would want to anyway, to ensure that we are mindful of increased staffing requirements in order to fulfill those service areas. Of course, we have a number of estates-related proposals either coming to this for discussion on this board agenda or for future board agendas. And again, we are due an estates refresh later on during this year. And in fact, I met with our Director of Digital yesterday, as indeed the Deputy Chief Exec has also done. And as part of those discussions, we have began a debate around ensuring that as we start to move into our digital strategy, that we were able to prioritise future digital requirements. Thank you.
Thanks, Jo. John, did you want to comment?
Yes, thanks, Mark. It was just the digital capacity bit. There's been a historical underinvestment really in digital for the organisation. I think that's picked up in the strategy document, and I think the intention is that any business cases come forward are going to clearly highlight where additional resource is required to be able to deliver things. But that prioritisation of work is a difficult challenge because capacity does not meet demand for digital services within the organisation, and we need to address that somewhere if it's going to be the enabler that we all believe it's going to be in terms of transforming the quality and capability of the organisation as a whole.
Yeah, I agree. Thanks, John. The final question for me, Mark, is one for Jill, I think. So robotic surgery and the robot Gela mentioned, of course, our intention was to have implemented that as soon as possible, and also the discussion of being implemented at YG. Jill, can you give an update as to where we are, please?
I can. I know Jo's got a hand up as well, so she may have an update. So in terms of the procurement, the all-Wales procurement across the robotic surgery, that is progressing. We do have arrangements in place to test some of the kit as part of that procurement within the YG site. That's been arranged with their theatre teams. So we are confident that during the summer that will have that will be landing. We shared that with CHC colleagues as well too, because they were keen to get an update on that. Joe may have a more recent update, conversations in CEOs.
Thanks, Jill. Joe?
I do. I met with colleagues in procurement yesterday. We are in the middle of a procurement process. And so obviously there are issues of commercial confidentiality, but we are hoping for delivery, depending on which supplier is chosen, in between early June or early July.
That's helpful. Thanks, Joe. Okay. So, Mark, we'll move off of that item. Thank you. And we'll move on, Jill, we'll move on, Sue, to item 3.5, which is your item, and the finance report month 12.
Thanks very much, Mark. So this report reflects the draft and audited financial report for the year ending the 31st of March. The Health Board set a plan for a 40 million deficit last year, which was based on the delivery of about 45 million of savings. And the plan was developed prior to the COVID-19 pandemic. And therefore, the Health Board revised the plan, as you'd expect, during the year in line with Welsh Government guidance. The month 12 position was of a 0.4 million surplus, which resulted in a full year position of a 0.5 million surplus, which is around 0.03% of our resource allocation. I'm really pleased for the Health Board that we have delivered a draft surplus in year, and I would like to thank Health Board colleagues and particularly the finance team for their commitment this year, and it's a really pleasing result for us. The delivery of the surplus was following the receipt of 40 million deficit cover funding, which was part of the 51 million strategic support provided by Welsh Government last year. The Health Board also used 10.3 million for performance improvement and 0.7 million to provide additional capacity and capability, and commenced the engagement and OD programme, and this was fully utilised in year. So last year really was all around the Health Board's response to the pandemic, and the cost of COVID for us in the year was around £172 million, all of which was fully covered by income from Welsh Government. There were some significant elements within there that I would like to highlight to the board. The field hospitals cost about 31 million. The TTP and vaccination programme cost another 13 million. And obviously PPE, which was a huge issue for us last year, which was really well supported by NWSSP colleagues, cost us about another £5 million. Just in terms of other elements, so we obviously were in a block contract arrangement with our colleagues from NHS England, and as a result of the revision of the second half year of the contract, we are anticipating about a 1.5 million refund against that block arrangement. I think the only other thing that I would want to highlight is a point that John raised, which is around savings delivery. So within the context of the COVID-19 pandemic, the Health Board delivered about 18.4 million. 11.3 million of that was recurrent, which was really a great delivery for us. I think other health boards have delivered within their draft accounts between 3 and 9 million. So you can see how well we did it as a health board. I think that's all I'd pull out of the report, other than to say that the Health Board's 2021 unaudited annual accounts and returns were submitted to Welsh Government on the 30th of April, and Audit Wales commenced their audit review the following week. And the board is requested to delegate authority to approve the 2021 audited annual accounts and the returns to the Audit Committee at their meeting of the 10th of June 2021. Just in terms of a final summary, so our targets for cash, capital and PSPP, which is our payment of non-NHS invoices within 30 days, were all met. And I'm happy to take any questions. Thank you, Chair.
Thanks, Sue. Again, John, is there any comment you want to make first as Chair of Finance Performance Committee?
If my microphone will turn on, yes. Thanks, Mark. Just really to support Sue's comments about the team. Got to have the congratulations in terms of what's been achieved to be able to get to the small surplus position. Obviously, that's been with the Welsh Government strategic support, but it's still a notable position to be in compared to the time I've been involved in the board. I think going forward, continued monitoring of any additional funding and monitoring of savings is going to be key, but recognise that we're still going to be incurring COVID costs in this financial year as well. So we're still not going to be in a normal position of performance to be able to monitor stuff. But no, it's a better outcome than we might have expected at the beginning of the year, and it's well done, really. Thank you.
Thanks, John. And of course, the board will wish you echo that, Sue, as well. Well done to you and the team. An observation from me, if I may. So, and it's one for you, Joe and Mark. In the NHS Chief Executive's letter to Joe around the 19.9 additional allocation, it's quite clear that there is understandably an expectation with the board that the direction of that expenditure should be shared and endorsed by board, and we've done that informally, but I think we need to do that formally. The same applies for the support package, which I think we've probably done, but we ought to just check that we've done it sufficiently. But more importantly, he refers to, doesn't he, that revisiting the plan to ensure that the impact of the additional monies, particularly the £19.9 million, are aligned to the plan, the ambitions within it, and that also receives the endorsement of the board. So I think we've got to ensure that we are discharging the expectations of the board set out in the letter, which I think are all understandable. Joe?
Yes, Mark, that is our intention. And just to further confirm that we are meeting with Welsh Government in a couple of weeks to discuss those issues and aspects of our to be refreshed plan. We do have proposals for consideration which would enable us to fulfil our obligations for accountability to the board and to satisfy those requirements outlined in the letter from the Director General of NHS Wales to myself as accountable officer. Thank you.
Welcome, Joe. That's helpful. Okay, so I'm going to move us off that item, Sue. Thanks again. The report is noted, and we do delegate authority to approve the audited annual accounts to the audit committee as usual.
Sorry, Mark, do you just want me to mention month one?
Oh yeah, sorry, I did ask you to. Yeah, let's do that. Thank you.
Okay, so just with regards to the new financial year, as the board are aware, the Health Board submitted a draft plan to Welsh Government, which effectively quantified the financial risk to break even at around 28.3 million. This was before we had been notified of additional Welsh Government allocations, including the 19.948 million. And obviously we are aware that there'll be further recovery monies available during the year. The Health Board has now finalised its month one financial position, and the result is in line with the draft plan effectively. So we've currently reported a 2.3 million deficit in month, which is obviously in line with that 28.3 million for the year. But this will be part of the refresh of the plan that is going ahead, which it's going ahead across NHS Wales, and that will be complete by the end of quarter one, so the 30th of June. Thank you.
Thanks, Sue. That's helpful. Okay, so we'll look forward to seeing the report on month one in due course. So we've done what we've asked, includes the delegating the authority to audit committee. So I'm going to move us off that item onto 3 point with Jill, nurse staffing levels and the annual assurance report. and I know this is an important topic, but again, there's a lot of information in here, and we are now running well behind. So can we do it by exception again, please?
Yes, I will do, Mark. And it's probably worth saying that we've discussed this at Quality Safety Experience Committee as well, to give further assurance. I think the critical points I would bring to your attention is obviously the assurance that we are complying in terms of the information that we're collating in line with the Act, that this was the triennial review where we were aligning harm against the very clearly against the staffing levels, and outlined within the report is obviously this was an extraordinary year, as we've discussed elsewhere in the agenda, where we have had to stretch our staffing levels, and you'll see attached to the report the letters from Welsh Government acknowledging that we would be extending staffing levels to support other areas which again have been discussed elsewhere in the agenda, including our MVIS hospitals, vaccination programme, and indeed backfilling where we've had absences and shielding. And I'd like to extend my thanks to our nursing staff who've been really supportive in acknowledging that we've had to redeploy staff elsewhere. So I'm happy to take questions by exception. It has gone through QSE. There was a debate at QSE that I'm sure Lucy can confirm.
So Lucy, anything from you?
Just to confirm what Jill said there, and it's been a challenging year, I think it's fair to say, isn't it? But yes, we did scrutinise this report in detail at QSE committee.
Okay. Any questions from anybody? I can't see any hands raised. No. Okay. So there are recommendations. 1, A to H, and 2. Are colleagues happy to accept and endorse those recommendations?
Yes.
Yeah.
Okay. Jock and Val. So we'll move on to 3 point now. That is with Teresa and the mental health update. Teresa, Of course, sorry, Teresa's had to leave for a IMT meeting, so we don't have Teresa with us. The report has been circulated, so are there any questions associated with the report? Or Lucy, if I start with you, is there anything you wanted to add or say, again, as the mental health lead?
Thanks, Chair. I think, the report just is really providing more granularity to the maturity matrix as part of targeted intervention and the joint working. So we've discussed the maturity matrix side of it. What I suppose I would just bring out is the importance of the baseline that Cheryl referred to previously. It's not the whole service, of course, that is it has been scored as 0. These are the areas that have been identified as needing the most improvement for both CAMHS and adult mental health. And that is why the scoring and the various stages as you move along the maturity matrix has been identified in that regard. We'll continue to monitor this as part of it, but I think you'll note, for example, in particular, the stronger and aligned management and governance that's mentioned in there as well on page 3. Taking into account again the disappointing internal audit report, that is going to be given priority. There's already been progress on that. The governance structures are much more aligned now to the health board and has been brought into the wider health board arrangements. So I think it's provided a really good framework actually as part of the targeted intervention work.
Yeah, Lucy. Joe?
Just briefly to draw board colleagues' attention to those areas outlined on page 3, which do acknowledge, whilst there is work to be done, and there is a commitment to continue to work in partnership, progress is already being made, and I'd like to commend the staff for their contributions thus far. Nothing further to add. Giacomo.
Okay, thanks, Jo. So we will note that report because I have no further questions being indicated, and we'll move on to 3.DEG, which is the primary care update. Chris.
Thank you, Chair. I could wax on all day about the things that primary care have done over the course of the last year. I'm not going to do so, you'll be pleased to know, and we'll take the report as read. However, what I will do is just touch upon the question that you posed earlier in terms of primary care access, and specifically access to general practice primary care as opposed to some of the other areas. The report does touch upon this, but I think it's worth just drawing out a few observations. There's a range of views in terms of how the pandemic has affected access to general practice. There are lots of negative views that are circulating in various different media fora and on social media. But alongside those, there are lots of positive observations too. I think in some respects, the narrative across the whole of the UK has been a little bit unhelpful for general practice in the last year. We've seen lots of pictures of the pressures upon hospitals due to the pandemic, but appear to have been a little bit less sympathetic to how those challenges may have affected other parts of the health service. And the reality is that general practice has never been busier and has had its share of challenges to overcome too. Remember that the majority of individuals with COVID never go anywhere near to secondary care, and those that do generally come out and require primary care care after their discharge. On top of that, there's a lot of secondary care activity, which for absolutely legitimate reasons we've had to decrease or suspend. And that has then had a knock-on effect upon primary care, who've had to seek to keep those patients safe whilst they wait. And that's created significant work. Infection control challenges in primary care. If you imagine how difficult it is in an outpatient setting, where you may be spending 30 minutes with a patient due to the time required to don and doff protective equipment. Imagine that in a 10-minute consultation, which is how general practice works. And consider some of our primary care estate challenges. They were not built to deal with pandemics like this, and some of those buildings are really challenging when it comes to keeping people safe when they enter into them. And then on top of that, as we've already heard today, primary care and general practice in particular has heavily invested time in delivering not just the COVID vaccination, but the highest flu vaccination season that we've seen for a long time too. All of that is on top of our normal primary care workload. So it is no wonder that primary care has had to change and that there is some degree of challenge and curiosity in terms of how that should be. We're in a position now where I think we should be establishing what the balance is longer term. I think it's true to say we've flipped too far towards alternative technology, but we need to be absolutely clear that we don't spring back too far to doing things in a very traditional way, where actually some of the technology has brought in improvements. And I would stress there are lots of positive observations to some of the alternative ways of consulting now, as well as some of the difficulties. The final point, I think, in response to your question is Whilst many consultations in general practice might start with the telephone or by email, remember, please, that doesn't mean a face-to-face consultation will not then occur if that's the right thing to do to bring about the best intervention. So we are on a journey. We are reflecting very carefully upon how to get that balance right to suit everybody. And I'm more than happy to hear personal stories and to provide updates as we carry on along that journey.
Yeah, Chris. So Lucy first.
Thank you, Chair. First of all, Chris, absolutely wholeheartedly support your comments there. I think, the challenges that primary care have responded to, when you consider, they are very small teams in buildings that many of which are converted houses. They have absolutely thrown themselves into managing the pandemic and have always remained, general practice has always remained open throughout the pandemic. Even right at the beginning, they were seeing patients face to face if they needed to see them and putting safeguards in place there. So, and some of our primary care colleagues, they've been particularly innovative, I think, in their approaches to managing the IPC challenges. If you consider a dental practice, undertaking aerosol generated procedures in a converted house, and how they've implemented improved ventilation, as an example, it's really commendable. Really interesting figures in here about the increase in activity. Now, some of that increase will obviously relate to uncertainty about the vaccination program, and I'm thinking here of the incoming, telephone calls and things like that. But there are also patients, of course, contacting their general practice, concerned about their referrals for treatment or diagnostic tests. Now, we can only manage demand for the first point, of course, to a degree through communication, etc. But information about planned care management is, of course, much more within our gift to address. And that this is where we can really help not just our secondary care colleagues, but our primary care colleagues as well in trying to manage that demand by improving communication. I'm not sure if this is a question that you would be able to answer, Chris, but whether this is our panel or Jill, but how are we addressing that to try and make sure that we're actually helping in the management of that demand?
I can answer it. Thank you very much, Lucy. I agree. Like many organisations, we've got off to a slightly faltering start in terms of being able to share some of that information in as efficient a way as possible. However, I'm really grateful to colleagues working in the secondary care planned care environment for working with my team to help pull that data together in a way which we can share, not just so that it's easier for primary care colleagues to access when they need to, but actually so that it's much easier for members of the public, for our citizens to be able to access directly. I can't sit here right now and say that we have that level of detail in an easily accessible format right now, but what I can do is sit here and say that over the course of the last few weeks, I've seen such a significant progress on it that I think we are very close to being able to share that information, and that's to everybody's benefit. But I do see Jill's hand up, so she may have something to add.
I think you've captured most of it, Chris, but I think we are very close now. We have drafted a letter to go out both to our primary care colleagues, but also to those individuals that are waiting, anticipating planned care coming back online, as I alluded to earlier in the board. So we're really close to finalising that communication, and Jo has indicated that will go out from herself. So agree with, and Chris's team have been really helpful, including we've had input for the whole of his team, including primary care GP colleagues, so that we're ensuring that we're getting the message right from both perspectives.
Jill, take this the right way, but that letter's been awaited for some time. So when you say soon, imminently, when do we anticipate that letter will be going out, please?
Can I confirm offline? But it has been agreed, but it was agreed, but then we've taken it back to the GPs. I understand our plan care colleagues were meeting with GPs last week to just finalise that. So I will confirm offline, Mark. Yeah. Just for the purposes of the board, it has taken some time. We've worked with lay partners to ensure that we've got the wording of that correct, and also with communication colleagues. So it's taken a bit longer than we anticipated. I'm very hopeful, and Chris has alluded to it too, that the partnership arrangement that's gone into place with our primary care colleagues and our secondary care colleagues will allow us to crystallise that very shortly, and I'll confirm offline.
Thank you. Okay, John.
Thanks, Mark. My question relates to the sort of activity and the demand bit as well. It was one of the observations, you'd mentioned the technology side, Chris. And on the bottom of page 12, I think it is, you've got this graph around e-consults. And I just wondered whether the use of the technologies actually created new demand or tapped into unfulfilled demand, or whether it's actually taken up that slack of where primary care can't actually do the physical reporting. Have we got a risk of ultimately an increased demand on services once we get out of the back of the COVID responses?
Thank you, John. We've had similar thoughts, and colleagues in the Primary Care Academy at the moment are working with practices to try and get to the next level underneath some of this e-consult data to try and begin to quantify and triangulate some of that, because I think you're right. I think there's a broad bag within some of those consultations. Undoubtedly, some of them are taking work away from face-to-face environments in a very effective way, but not all of them are, and some of them will then end up with a face-to-face appointment, and you could argue, did that e-consult necessarily add much value? And some of them have picked up unmet need, as you referred to, some of which sometimes is really important, unmet need. And we need to understand that a little bit further. So there's a lot of work underway on it. I've seen some drafts in terms of how they're trying to get to that. It's very difficult because of how we the range of different coding options that you have in primary care. Sometimes very difficult to just articulately capture that, but that's the task in hand, and I'd be happy to share it with you.
All right, thanks, Chris.
Thanks, John. Linda. You're muted, Linda, or there's a problem with the connection. No, still can't hear you. Your mic is shown as off here. While you're trying to sort it out, I'll turn to Avion, Linda. Avion.
Thank you, Chris, for your comprehensive report as normal. And as you say, the GP surgeries have been doing tremendous work over the last 12 months and have never been busier according to the April figures in front of us. But it does still show that the majority of consultations are still done over the telephone. I'm sure that the GP surgeons are taking a balanced approach in that regard. But I noticed last week that NHS England have sent a letter to all GPs saying that patients' preferences for face-to-face consultations should be respected. Could you tell me what the Welsh guidelines say in that regard?
Thanks for the question, Avion. There isn't the same general communication that has gone out on a Welsh basis, but our position with contractors is pretty much no different to how it has been evolving over many months now, which is that absolutely telephone or video consultation has a role to play, particularly when you're trying to deal with infection control issues, and let's not forget the convenience to individuals who don't necessarily see it from the same perspective as we do when we drag them all across town just to come for a few minutes of a conversation that could have happened just as well by phone. That is absolutely important to get a balance with that, but absolutely at no point should that be at the expense of being able to do a better assessment on a face-to-face basis. And that might be an assessment that you make as a professional, but actually it may be that your patient in front of you feels that they will get a better experience from that. So we've always advised our clinicians to take a pragmatic view, and we've always taken the view that we will support them in any correspondence with their patients accordingly. I have to say the number of complaints that have come in to me or to any of our primary care teams across North Wales have been very few indeed. So I think most of our contractors are getting that right. But we haven't provided explicit guidance other than the fact that the prevailing objective of a consultation is not to do it as easily as possible for the professional, but to do it as clinically effectively as possible.
Thank you, Chris.
Yeah, okay, Beyond. Linda, you may have a mic now, I think. Do you want to try? No, your mic is shown as on, but we can't hear you. No. Okay, so I'm going to move us on then, Chris, if I may. So I'm just going to, a couple of issues for me, Chris. So as I said earlier on, there was quite a lot of news coverage on national news this morning about pressures on primary care, the fact that demands increases, there are staffing challenges, demand for GP has gone significantly up, and so on and so forth. Do you think we're doing enough locally to communicate that dynamic in terms of the pressure that primary care in particular and GP practices are under to help the public understand why there are some of the challenges out there that we're seeking to reconcile?
So I guess the inevitable answer to that is no. And I would say we're probably doing less now than we did do earlier on in the pandemic in terms of explaining some of those challenges. So there's some work for me to take away on that. It's fair also, I think, to point to some of the national communications work which we're contributing to with a view to trying to get a more consistent message out there and to use some of the national platforms as well as some of the local platforms. So we'll bring that in as well, and I'll go away and have some conversations with the comms team.
Thank you. And then you would have seen it, Chris, it's not for a comment now, but Joe circulated a really helpful update of matters discussed at national meetings this week. And there was quite a lot in there around primary care in terms of what might be achieved by improvements if investment is increased in primary and social care, in terms of also whether there is a transition and an impact as a consequence of accessing primary care by way of people turning up at ED for routine medicine and so on and so forth. It's due to be discussed on Monday with Jill and Joe, and no doubt you'll be involved at some point, but it certainly gave food for thought from my perspective in terms of some of the dynamics going on. Have you seen it?
Yeah, I have seen it. I agree, and we'll be contributing to it.
Thank you. Okay, so if people are happy, then I'll move on from that item, and we come on to what is arguably the most important item for the Health Board today in terms of our discussion, and that is vascular. And the purpose of this item is to discuss, in the main, a report provided by the Royal College of Surgeons, which I think is important to recognise that was commissioned by the Health Board because of concerns within the Health Board and among stakeholders in terms of the centralisation of vascular, the impacts of that centralisation, and whether expectations were being met in terms of the areas that were to receive focus and improvement. And I do think this is an important discussion that we need to air, of course, in this forum, but we also need a very clear sense of how we are going to move forward in response to the concerns that have now been identified by the RCS in a review that we commissioned because of the concerns that existed. So before I come to you, Arpan, I'll go to Joe first, if I may. Joe?
Diolch yn fawr, Mark. I'd like to thank the board for commissioning the Royal College of Surgeons report, which we are discussing today, and acknowledge that the report supported the centralisation of vascular services. I'd also like to acknowledge the importance of progressing the findings in the report, particularly, but not exclusively, including those associated with the diabetic foot pathway and the use of and availability of vascular beds. And I understand the disappointment of IMs with regard to our progress in this regard. Before I hand over to Dr. Guha, which I will do in a moment to go through the detail of the report and our response, I would just like to draw your attention to the fact that the Royal College are yet to finalise the case review. And in due course, and with regard to patient confidentiality, I would like to confirm that it is our intention to share the findings of that aspect of the report openly. We are also intending to share the report with our external healthcare regulator. And I would now like to hand over to Arpan to go through the detail of the report. Diolch yn fawr.
Thanks very much, Chair, and thanks, Joe, for that introduction. As has been mentioned already at a public board meeting in May 2020, the Health Board started a process that approved the establishment of a vascular task and finish group, and of course, as part of that process, also commissioned an external independent review of the vascular service from the Royal College of Surgeons of England. As Joe has alluded to, the review was commissioned and consisted of two parts. The first part, which has been concluded, is an assessment based on interviews and examination of documentation. And part two of the review is still to commence and includes a thorough scrutiny of 50 sets of clinical notes. We are still awaiting confirmation from the RCS, and this delay has been due to the surge of the COVID pandemic, which has prevented RCS colleagues from reviewing the notes. However, they have confirmed that with the reduction of incidences of COVID-19, they are happy to come physically to Betsy Cadwallader and examine the notes physically. So we are just negotiating a date for that process, which will complete it. As Joe has said previously, this part of the review will be shared in a transparent manner to enable us to learn further. I think at the outset it is helpful to acknowledge that there has been insufficient progress in implementing the recommendations that were identified through the previous reviews that have already been mentioned. And this lack of progress has also been captured and articulated within the RCS report, which is attached as Appendix 1 in your pack. The thing to note is that the report identifies 9 areas that require immediate improvement to reduce any impact on patient safety. And in addition, there are areas where further improvement in the service model is also recommended. Taking these recommendations on board, what we have done is we have refreshed the vascular improvement plan, which now has incorporated all the recommendations of the first part of the RCS review, which is with us. And this revised action plan will see progress being made at pace. And the action plan itself is attached as Appendix 2 in your bundle. I would also like to say that it will be my intention to seek the board's approval to invite the Royal College of Surgeons back for a repeat review and to share that this particular review with our regulators after the board meeting, as well as after the clinical notes review process, which is yet to conclude. It is important to state at this stage that despite the fact that the report provides many recommendations to improve the service, it does make some valuable observations which are important for us to note. There is an observation made that there is a framework of valuable clinical MDT expertise in both the hub and spoke sites, and I think this bodes well for the future. There is also a mention in the RCS review of an overwhelming commitment from those that were interviewed, and everyone is committed to working together. So this is clearly a good foundation on which to further pursue our improvement plan. In terms of the 9 urgent recommendations, they are clearly mentioned in the review process itself. So I'm happy to go into the details of them should members wish. And as well as the 9 recommendations, there are also 2 broad recommendations in terms of service improvement as well. In terms of some update on key areas, members will note in the action tracker as well that work has obviously is now sort of gathering pace and momentum, and in particular the alignment of the vascular inpatient bed base is something that we are also pursuing with a degree of energy. That requires a number of pieces of data and information to be gathered and analyzed so that we know exactly where the clinical pathways would support the beds being there, as clearly some of the clinical information and the thinking has changed since the initial conversations took place. So we are looking at the overall usage of vascular procedures and beds since the centralization in 2019 in that regard. The diabetic foot pathway has been really slow in terms of taking off and progressing. However, I'm very happy to now state that it has already started to do its work. A multidisciplinary group has been formed, and it is led currently by one of the national leads in diabetic foot, and is one of our leading podiatrists. And he is leading the process with a diabetologist who is also the hospital medical director currently of Wrexham Milo. And both of them are leading this process for across the health board so that we have a single, unified and agreed pathway that is based on the most recent clinical evidence, such as NICE guidance. One of the things to say about this process, which has already met on the 11th of May, and it has carers as well as patients in that particular group, so that we can hear the patients and the carers' voice in order to determine what is the best pathway for patients and users in North Wales. One of the things that we have noticed as part of our preliminary analysis of the foot care pathway, which is complex, is that we required orthopedic expertise as well. And currently we're in consultation with one of the leading centres in London to make sure that we get a service level agreement in terms of that orthopedic provision should that need arise in North Wales. Some of the other pathways are also mentioned, which are progressing. Some of the pathways, to be fair, have already been completed as part of the original remit of the task and finish group, and some of them are on the verge of completion and soon to be submitted to the clinical advisory group, which, as you will know, is a group responsible for checking and endorsing pathways of care in Betsy Cadwallader. There has also been a good process in terms of communication and engagement with our patients, as well as commissioning of a patient safety culture survey within the department, which is being further analysed because there is a lot of complex data in it. And when that exercise has been completed, it will be incorporated into the overall improvement plan as well. So that is all I wanted to say at this stage, but obviously happy to answer any questions should they arise. Thank you, Chair.
Thank you. I'm sure they will arise. Shall we start with Medwyn? Medwyn.
Thanks very much.
Thank you very much, Chair.
While acknowledging that you mentioned previously that there weren't any red flags as such highlighted within the Royal College report, the report does, however, flag that there has been, as you mentioned, insufficient progress in implementing recommendations. And this lack of progress is extremely disappointing since the new service went live, causing, and I'm sure you'll agree, some concern for the population of North Wales, with also reputational issues for the board as a whole, as the Chair alluded to earlier. And I know it's easier to be wise after the event, and in hindsight, everything is a lot clearer. However, the report identifies, as you mentioned, a long historical list that requires immediate improvement, and I'm quoting there, and several areas where further improvement in the service model is recommended. Which then begs the question, does it not? Why have these improvement areas been identified and highlighted now, given the assurances that this board was presented with originally prior to the decision to centralise the service, and given the concerns raised at the time by various individuals, groups and stakeholders? So given the reports to date, would you concur that the issues highlighted should have been addressed right from the start of the new model being introduced, and more importantly, lessons learned? And why has it taken so long to implement these recommendations? Which then leads us to the current situation and position regarding the standard of the service that we provide the population of North Wales regarding vascular services now. What do we believe the standard of our vascular services are now? Thank you.
Thanks very much, Medwyn, for those questions. So in terms of your observation, clearly when the service was started, there would have been agreement of a target operating model. And I do believe that for a number of reasons that there has been slow progress, which we all acknowledge, and it is disappointing. Part of the reason I do think the reason why there has been slow progress in terms of operationalizing some of the elements of that particular model has been because of COVID, without a doubt. I certainly know that the vascular service, there were a number of individuals who were drawn away, not just in the service, but overall in the task and finish group to address some of the COVID responses. So as a consequence, I think some of those sort of areas which should have progressed at a much greater pace perhaps did not. I would certainly like to think that with the additional recommendations that we have now incorporated and included in the task and finish group recommendations, our improvement trajectory will move forwards at pace. And we certainly have some early indications that is indeed the case, as is reflected in observations that I've just made in terms of the diabetic foot pathway as well. And it is about sort of considering how we move forwards as a health board to make sure that we continue to deliver a higher quality of service, as you quite rightly observe, for the population of North Wales.
As you'll know, many of us have been expressing this for the last 2 years, and we are extremely frustrated by the lack of pace and the reports which have come out. And I know you're fairly new in your position, Arpan, and I appreciate your taking up the mantle, but this needs sorting out as soon as possible. Thank you.
And indeed, with your permission, Chair, if I can say that, I have certainly made that commitment to follow those elements through, certainly.
Joe, did you want to comment at this point before I bring in John?
Sorry about that. Thank you, Mark. Just to add to Arpan's comments, to confirm the commitment of the organisation to ensure that the outstanding aspects of implementation are put in place, and the progress that we have seen most recently as we've moved out of COVID-19 is maintained for the benefits of all of our patients. Jochen.
Okay, thanks, Joe. John.
Thanks, Mark. The thing that struck me in particular about the report and our response is about the pathways side of things. And given that pathways were key when we implemented this change 2 years ago, it's concerning that we're still in a position where pathways are not yet concluded or completed. Now, I understand, though there is a level of complexity there, but 2 years down the line, it's disappointing that those haven't been completed. And I think my further worry and concern here is going forward, I'm not sure I get a sense of urgency from what we're getting reported to actually complete them and to resolve those issues with the pathways. And I just wonder, how do we get that assurance that there is that sense of urgency of dealing with this?
Thanks very much for that question, John. Well, first of all, let me once again say what I said in my introduction about my acknowledgement that the progress has been slow and has, of course, been picked up by the RCS report as well. In terms of pathway, as some level of early assurance, if I can just reflect on the diabetic foot pathway, for instance, you will notice from the action plan that we have set ourselves a targeted completion by June, and so far things are on track. We've had, our first meeting has already started, as I said. We are progressing with other meetings absolutely in the diary. For the first time, we actually have that multidisciplinary engagement that was difficult to get for a number of reasons. One of them is COVID, but the other, of course, is trying to actually ascertain where the expertise in particular fields lay, and looking through the health board to achieve that. So as early assurance, I can certainly say that, if I take the diabetic foot pathway, which has clearly, for all sorts of correct reasons, have been the focus of attention, the work is going on at pace, and we certainly will pursue that with the energy, and we have set ourselves a very challenging target. In terms of some of the other pathways, John, you will notice in the action tracker that some of them have actually been concluded because the work did not stop. I mean, the RCS came and reviewed us, of course, but as we debate this aspect in May, a number of those pathways have actually been concluded, presented to the clinical advisory group, and awaiting implementation. So hopefully that goes a little way, perhaps, in providing assurance that things are going to be different.
I think the assurance is the speedy delivery to move things forward.
Indeed.
Okay, thanks, John. Avion.
Yeah, diolch yn fawr iawn.
Yes, thank you very much, Chair. And thank you, Arpan, for the report. I understand he's in a difficult position and the report is disappointing, and we have to accept that and have to accept that much work needs to be done. Of course, it's been a blessing to have an independent report from RCS, and I'm very pleased to hear that you're going to arrange another report. So it would be good to know maybe over time when that will be available to us, and I'm pleased to hear that. One question I wanted to ask you, Arpan, and your professional opinion. There are voices outside the health board suggesting that we should be turning the clock back and reorganising services again. What is your opinion on that suggestion?
Thanks very much, Avian. If in terms of your first part of the observation, yes, we are all disappointed because we all wish to do the best for the population of North Wales. I don't think that there is any argument with that, and we are all certainly committed to delivering the improvement plan as it stands at the moment. In terms of the service model, I think I personally don't think that the evidence supports anything but a hub and spokes model. It is certainly reflected in the Royal College of Surgeons' current review process. It supports the centralisation. What it does say is that the implementation of that is something that we now need to sort of focus our attention to in a much better way than we have done previously. And if I reflect on, let's say, similar vascular reconfigurations which are being contemplated in other parts of Wales, for instance, they are certainly based on the same or a similar kind of model that we have in North Wales at the moment. And in terms of the clinical evidence, which you were asking about, there are a number of documents, not least of, I can quote one, Getting It Right First Time in Vascular, which was published as a UK-wide document, clearly articulates the benefits of having a centralised service and a hub and spokes model. So to my mind, it is about moving forwards and with energy and with pace, implementing that particular model.
Diolch yn fawr.
Thank you.
Lynn.
Thank you, Arpan. I'm struggling with this report based on the fact that the RCS have made 9 urgent recommendations, and yet it says that there's no red flags. So I find that difficult to tally. If you could give me some assurances there.
Surely. So what we know from the RCS report is that it is making observations on the direct surgical clinical outcomes, and they did not find any red flags for areas such as mortality, readmissions, or length of stay when they have analysed the nationally comparable data, which is the National Vascular Registry data. So that is what they're referring to. And clearly what they have mentioned, as you rightly point out, and I spoke about that as well, are the 9 recommendations that have the potential of impacting on patient safety. And those are the ones that we are obviously also pursuing with energy and hoping to implement as soon as possible to minimize those risks for our patients.
So do you feel that we have enough and sufficient resources in to get these 9 urgent recommendations resolved much quicker than what you've anticipated? Because it is a concern that if they're urgent recommendations, something may happen.
We, following on from the report, which has been incredibly helpful, we've had a number of internal meetings within the executive team, and as you will notice, we now have significant senior operational leadership and management support for this, because one of the things that has been noted is exactly that. It's the operationalizing of some of the models that has been delayed and caused the disappointment that we are obviously all sharing in at the moment. So yes, the resources have been forthcoming in that sense, and certainly in my covering document, I have made reference that there may be requirement for some additional resources as well. But we've certainly discussed that within the executive team then.
So I fully appreciate what you've talked to us in the executive team. Can you tell me, just the average member of staff who work for Vascular, are they aware of this report? Are they aware of the urgent recommendations and the concerns that we have as a board?
So the plan, Lynn, and I've already spoken to the service, I'm going to speak up, because I do think that for a number of reasons, the service needs to be supported through the actions, and so I'm actually running a summit with the service, and that date is to be arranged. Obviously, as it was a board commissioned report, the appropriate route for that is for the board to be presented with the report and accept the report, and then we move forwards with that. So the answer is yes.
And I think of all the things that need to be done, that the staff themselves need to see this report as quickly as possible.
Yes, absolutely acknowledge that. And as I say, I've already started liaising, not now, a few weeks ago, and we're just trying to get a date when we can get the majority of the staff together.
So my final question is, if I was needing to come into vascular department, am I safe? So
that is a question, Lynn, that I've asked myself and tried to sort of put myself in the position of the patient. As I've already said before, and as the RCS has independently said as well, at the moment there are no red flags that they can find from the comparative data across the UK in terms of the actual sort of surgical clinical outcomes, if I can describe it that way. The service itself has the usual recognizable clinical governance mechanisms. So I would personally feel confident to present myself if that day should arise to the vascular service, and including my family as well. Now that, of course, is a very subjective comment, is it not? So as one of the things I've done to make sure that there is further objective scrutiny of the clinical outcomes, I have actually sort of referred all significant adverse events and deaths to the RCS process of the clinical notes review, so that there is almost, I would describe it as a third level of scrutiny, which is independent and will be undertaken as part of that. That wasn't in the original remit, but I have added that on because I did feel that that was the right thing to do. So when that review process is concluded, Lynn, I think we will hopefully have the opportunity to understand this in a much greater way and a much greater depth.
My final question, Arpan, as medical director, are you taking full responsibility for vascular now?
So that is something that is an ongoing discussion with the chief exec, but certainly there are strong clinical elements to this process, and I have certainly said that, you know, I am exceedingly happy to lead this process, but this is not a piece of work that can be done on my own. And as you would imagine, I have benefited immensely from almost every member of the executive team. All my colleagues have been helping me in numerous ways, more than I can say. So there is strong support to make this happen, which I think also, if I reflect back on a previous question that you asked about resources, addresses that in a different way.
Thank you. Thank you, Arpan.
Thanks, Liv.
So we'll go to Lucy next.
Thank you, Chair. So at QSE committee, one of the frustrations in being able to evidence progress against all of these actions that we've discussed comes back to the granularity and the specificity of the actions themselves. And Arpan, you know, you and I have had that conversation. A number of the actions in the action plan attached, I think, are still too vague to be able to effectively monitor and evidence progress. So if I take an example, sort of review and refine pathways, and I appreciate some of this predates your involvement as well, Arpan, but review and refine pathways. In what way? To what end? What outcome are we trying to achieve? So it's easy to then report that as, well, we've reviewed and we've refined the pathways. But what isn't clear then, and the organisation and our patients then can't be confident about, is what has been the end result of that? What was initially achieved? What was initially, what the initial objective was of reviewing and refining those pathways? Without that, the board cannot be confident that the service is safe, and unfortunately we risk making the same mistakes again. So, I mean, patient safety, and I know you agree with me here, patient safety has absolutely got to be our priority. And given the history, it needs to be absolutely transparent what is being done, when and how that's being done. And we also need to be confident that any findings arising from the next stage of the review, the case notes, that there will be a rapid and robust response to that as well. So I think there's still a lot of work to be done in relation to the monitoring and reporting of progress of this, for everyone to have confidence in how we're moving these things forward. And we've had a discussion before as well about the fact that there is a difference between the role of the task and finish group in relation to managing these actions and expectations, and actually the development of the service itself and the implementation of that new service review. So I think it's important that we don't conflate those two issues and lose focus then on what we're trying to do, and make sure that we're being clear, that we're learning from what's happened, which we can't unwind the clock. We are here now. That's not acceptable. You know, I think we've all acknowledged that progress is just, the lack of progress rather, is not acceptable, but we have to be able to evidence that improvement now.
Thanks very much, Lucy. I absolutely agree with everything you have said. In terms of the pathways, I have made a note of the observations you've made. You're absolutely right. We need to articulate that in that document a little bit better. But I can certainly provide you with some reassurance that when we wrote that particular action, what we were meaning is that we will actually monitor the clinical effectiveness of the pathways and make sure that the evidence is actually recorded and not simply accepted because it's been said. So absolutely take that on board in terms of improving that process. Yeah. And also, once again, as you rightly say, you know, there cannot be in my mind any disagreement that the most primary thing is patient safety. It trumps everything, in my opinion, and I know it does for you as well.
I suspect Lucy was only using the pathways as an example. Can I ask that Lucy, as chair of QSC, and you, Arpan, subject to what we discussed in a moment, take that outside and confirm that you're both happy with the description of the actions and outcomes before it returns to board, which I'll come on to in a moment.
I would certainly value that.
Yes, absolutely, because I think it is important. We absolutely have to move away from reassurance and get into that space of assurance. So very happy to work with our panel on that.
Thank you both. Yeah. So Sue Green and then Joe.
Thanks, Mark. I suppose I wanted to come in really to support our plan, because clearly he is the focus as the medical director, but this is something that clearly needs the combined resource of the executive team. And I suppose I'm going to say something that I said in 2009 at a board meeting, and it's largely in response to the question about should we be considering a change in the original decision. And I think we come back to the evidence in terms of improved outcomes. It also probably relates to Lynn's question. Would you be safe? And I think there's something about recognising the evidence that was used to make the initial decision in 2013, that was then endorsed and emphasised by the Royal College of Surgeons following their review in 2015. So I think one of the points I wanted to make was this is a change that has been made for the right reasons. It has been made for the right reasons based on patient care and securing better outcomes. It has been made on the basis of following a public consultation, but it is the execution of the change, and the execution of the change requires the people aligned to the change to be aligned with the decision. And the report from the Royal College of Surgeons last time and again this time does refer to a sense of bereavement and needing to manage that a little better than we have with the respective staff that are involved. I do feel, and supporting our pan and colleagues in this, I do feel that we have a team now that is more aligned. The feedback from the Royal College in the Royal College of Surgeons report definitely is an improvement on the ability and the willingness of all parties, both in the hub and in the spoke, to make this work. And I think this is what we really need to be focusing on as a board. Acknowledging and agreeing with all of the points that have been made in terms of we need to not take reassurance, we need to be securing assurance. There absolutely needs to be a more clear and focused input into making sure that the pathways across the hub and the spoke work, and we need to be engaging with the patients and community who'll be using the services, as well as clinicians. But I think it's really important to keep it at the level of making the pathways work, and less about a change of decision. I also think it's really important, and the board has done this today, that we keep the conversation about the patients and less about some of the public commentary around some of the individuals concerned, which actually I don't think has helped, and I think could be a distraction from making sure that we keep the patient at the centre of this decision making and improvement.
So thanks, Sue. Before Joe and Jill come in, though, I think I need to respond to some of that. So I think the board is entirely within its rights to seek assurance from the executive team that the original decision remains apposite and appropriate. And I think we need to, in those regards, express and recognise the concern that back in 2019 and since, 2 previous medical directors have provided assurance about the pathways being in place and other considerations being addressed, including the availability of beds at YG and also some other aspects that were detailed in the original proposals and that were explored back in that workshop. Take that with the fact that the board asked for a review to be carried out, an independent review. We then discover the initial review had been carried out internally, and therefore we had to insist on an independent review being carried out because of the concerns that existed within the board and outside too. And it is very clear that the stock of the independent review is in some significant degree of stronger input and import than the internal review. So we have to feel, I think, vindicated in pushing for an independent review, and that's what we've now got. So I do get your observations, Sue, but this is of course, the demonstration of the concern that existed and has built up over some time, in part because of what has been said to the board in a variety of forums, and which do not now correlate with the now independent review that's been presented to us. And I think before Joe and Jill comment, there's a couple of things that we also need assurance on in that regard. So whilst I hear it's for Joe to identify who is leading this response, and I recognise it might be a team response, but we are now at the point, based on what I've just said, where I want to be very, very clear as the chair of the board, where responsibility for moving this review and its recommendations lies in terms of the organisation and the executive team. I've heard a comment made that the executive team is considering the investment of resources to move the recommendations forward. I'd like to know when you're going to make a decision, because this is 2 years old now in terms of this topic, and this review is really important in moving the concerns and addressing the concerns forward. I hear that no date has been fixed for the meeting with staff. Well, I would like to know when that date is going to be fixed then, given the nature of this report. And finally, in that regard, we are entitled to a clear sense of progress being made, and I hear what's been said, but I will be expecting, no matter what is now said after this description, for this to come back to the board next time, because this is now going to the heart of confidence and reputation of this board, and the board needs to demonstrate that it is closely monitoring progress through QSC committee and onto here. So I'd expect this to be a standing item for the next meeting and probably beyond, until we're all satisfied that the concerns that exist have been addressed and closed. Joe.
Thank you, Mark. So to confirm that ARPAN is the SRO for the ongoing oversight of the implementation of the findings associated with the Royal College review. And of course, as we've acknowledged, that is most definitely a team effort. But in all team efforts, there needs to be a team leader. And I'm very clear, as is ARPAN, that he is our lead for these pieces of work. And of course, we'll be happy to bring a progress report to the board, keeping you all cited on how we are going as we work through and maintain the progress that we have developed thus far. Thank you.
Thanks. Joe, did you want to come in? Jill, still your hand's dropped, so I take it you don't.
Sorry, I was trying to multitask there, Chair, and failed miserably in terms of taking hands down, etc. Just to recap as well, that we talked in the beginning about our targeted intervention framework and our improvement matrices. And one of the key issues that's come out of this is around communication engagement. It has come through here. Equally, the assurance piece around governance. So I think we need to consider the lessons of vascular, and I know that that's been inherent in terms of co-production and moving forward, redesign of our services. It is clear that we do need to learn lessons from this and support the principle of the oversight of the board. But we need to ensure that that engagement process is robust and pathways are in place before we move services in future and put the patient absolutely at the heart of everything we do.
Okay, absolutely agree. So can we just confirm the actions that we've agreed then? So in acknowledgement, ARPAN, that you have been identified as the lead, albeit with the support of the team, I'm expecting that the reports of progress will largely come from you moving forward. can we confirm outside the meeting with the executive team, Joe, that the required resources have been invested when they are invested, given the point made in that regard by ARPAN? And ARPAN, can you let us know outside when the planned meeting with staff is to take place, please? And then we also agreed that Lucy and ARPAN will come together to look over the agreed actions and outcomes. And finally, ARPAN, the next update will be to next board in 2 months' time.
Yeah, I'm quite happy with the actions for myself and on behalf of the team.
Okay, all right. Well, we'll pause it there for the moment then, and we'll be returning to the subject, no doubt fairly soon, out with the board committees anyway. Okay, right. I will stop that conversation there, and we now move on to a lunch break. So can I suggest we have a break from now until, let's say 2:20, 25 minutes? Is that okay with everybody?
Yes, thanks.
Okay, right, thank you. We'll stop there, back at 2:10 then. Thank you. Diolch.
Ti eisiau mynd i nôl dydd?
been able to get back to you since you sent the message yesterday.
Oh, that was a mistake.
Okay, Christ all in all, shall we welcome back? Shall we now carry on? I'm conscious of the time, and I've indicated in the chat that I'm taking the decision now to take out the planned care recovery item from this afternoon and move it on to the workshop on the 3rd of June. We have got the presentation from Jill. So if there are any questions, by all means, I'm sure Jill and the team will respond to them. But otherwise, we will be discussing that and unscheduled care and a response to unscheduled care on the 3rd of June to give us some time back for this afternoon. So that being said, we'll now go on to the remaining items, which start with full decision. The first, Pedro Point Dean, seeks amendments to standard orders and SFIs. It's with Louise, but I'm going to ask whether there are any comments that need to be considered and discussed rather than agree that the amendments can take place. So if you're happy, Louise, can I ask the membership if they're happy to support the amendments, and if not, then we can move to discussion? Is that okay with you?
That's absolutely fine, yeah.
Okay. So our colleagues happy with the amendments?
Yes.
Yes. Yes.
Okay, so if you're happy, Louise, then we'll accept the amendments. I guess you are, because you're proposing them. So we will then complete that item in that fashion. Thanks, Louise, for bringing those here. So we'll now move on to Petra Point Die, which is with Chris, and is the pharmaceutical needs assessment. Again, Chris, I realise this is a comprehensive report, but it is going out for consultation, so will be coming back to us. So in its presentation, Chris, can we recognise that now?
Absolutely, thank you, Chair. Very briefly, the pharmaceutical needs assessment is a piece of work that we have to do due to a change in legislation. It's the same for all health boards. We've taken a broadly similar approach to the other health boards. The only thing I want to draw out very clearly is my personal thanks to the little gang of folk who have worked upon this at a time when, quite frankly, there were lots of other pressing issues for them to be dealing with. So I'm really pleased this has stayed on time. They've got to a point now where the assessment is completed in draft format, which then requires us within the legislation to go out to 60-day consultation. That is what is in front of you. Following that, on the basis that you're supportive today, then following that, it will come back for final sign-off.
Okay, so any questions or observations? I can't see any hands up. Lucy.
Yes, sorry. As part of the consultation process, Chris, can we feed in comments to you as well?
Yes.
Yeah, so I won't raise anything here then. I think it'll be, we can just keep in touch on the developments.
Perfect.
Thank you.
Chris, can I ask, as things currently stand, of course, it identifies some gaps in service provision potentially. So, assuming that does not differ following the consultation, what happens then if you take me? Because some of them are quite significant, I would imagine. I guess suppliers against demand and the gaps will be an issue. So, what's intended to happen on the back of it, Chris?
So indeed, I mean, the reason the legislation has come in is because the historic process isn't really fit for the way that pharmaceutical services work now. So it ought not to come as a surprise to us that there are some gaps. We've been really clear about laying our assessment out on a cluster footprint because we feel that the best conversation in terms of how to address those gaps needs to occur on the ground within those individual localities. So when the assessment has been through the necessary processes, all 14 of our localities will be asked to work through their respective sections and put forward proposals of how they feel we can address those or as many as possible of those shortfalls as simply as possible. In the longer term, as contracts come up for renewal, as providers seek to change their services, they will all be informed by the assessment as it currently stands. So it will be an iterative process, but starting off with the 14 localities, identifying any easy wins.
Thanks, Chris. That's a helpful explanation. Okay. So I see no other hands raised. So that being the case, are colleagues happy to approve the draft PNA, approve the commencement of the statutory 60-day consultation period from the beginning of June?
I'm done.
Yeah. Others happy?
Yes.
Yes.
Okay, thank you. Thanks, Chris, and please thank the team for what is clearly a demanding and comprehensive piece of work. Thank you. So we'll now move on to Ysbyty Gwynedd Hospital, Mark, and the fire safety and infrastructure business case.
Cheers. Thank you, Mark. So the estate strategy in 2019 set out the challenges facing us in terms of our physical estate, both its ageing nature and the extent to which it is functionally unsuitable in a number of key areas. As I think we're all aware, the discretionary capital allocation that we receive from Welsh Government, this is a sum of money that we can spend kind of on our own according to our own purposes, is really quite small for an organisation of this size. It's not much. It's no more than 1% of our revenue allocation, and therefore the response to the challenges we face in terms of our estate has to be business cases and proposals that we put forward to Welsh Government for all Wales capital, and this falls into that category. We have made significant progress in many ways in this area. We completed a 10-year refurbishment of YGC in 2019. We've got an approved programme business case for infrastructure issues at the Wrexham Miler that was approved in 2019, and we're bringing forward an outline business case in the summer of this year. So this third scheme that relates to Ysbyty Gwynedd completes this our seeking to address the challenges we face on our three main district general hospital sites. So that's the strategic context for the case, but there is also an immediate driver, and that relates to fire safety concerns. North Wales Fire and Rescue Services have identified deficiencies in relation to fire protection measures that do require to be addressed, although they're equally clear that they don't imperil the continued use of the hospital, and I need to be clear on that aspect. Once we're doing work to address the fire safety concerns, it makes both economic and practical sense to address the other aspects of the ageing technical infrastructure on the site, which has had very little spent on it of any significance since it was built, I think, some 35 to 40 years ago. So this is a strategic case. There will be individual detailed cases that will look at the individual elements subject to support from Welsh Government. And in considering this case, I think the key question and the key answer to give from a strategic perspective is that we do envisage a hospital on that site in Bangor for the next 30 years. We simply can't conceive of any circumstances under which that wouldn't be needed. And that being the case, it makes sense that we propose to complete this much needed update to the technical infrastructure on the YG site. It will also allow us to address some of the learning from the recent pandemic, look at the opportunity to provide improved segregation, better ventilation, etc. The case has been supported by the F&P committee at the end of March, and I'm happy to take any questions on it. Thank you, Mark.
Thanks, Mark. Just to confirm, I think you said it, Mark, this has been for F&P already, isn't it?
It has, yes.
Okay. Any questions or observations? I can't see any hands raised. No, okay. The offer there, Mark and team. So that is approved for onward submission. Thank you.
Thank you.
We next come to the DTCs item. Edward Point, Edward, Mark.
Okay, thanks, Mark. So a previous version of this strategic outline case was also approved by the Finance Committee at its March meeting. I'm going to talk about the change that we made in this case shortly. First, I just want to highlight that the proposal remains an innovative one in that it seeks to separate out elective care from unscheduled care delivery, and thus make sure that we're able to more easily maintain our flow of elective work, irrespective of unscheduled care pressures or future pandemics. The proposal will see us reducing waiting lists as a result of increased efficiency and productivity, improving clinical outcomes and patient standards through the application of consistent clinical standards. And then finally, we would expect to be able to reduce the time to first appointment through introducing proactive clinical triage and what we call one-stop shop approaches. So this is a genuinely innovative and forward-looking proposal. Since the SOC was approved by the Finance and Performance Committee, we've made a change to amplify our commitment to explore the full range of options at the outline business case stage. And we've been more explicit that those options could include innovative approaches to the funding and delivery of these services that could see a greater role for the private sector. So I think that was always implicit within the case as a strategic outline case, but we just wanted to draw that out a little bit more. We will be keen to do that if that met our needs to improve to deliver the objectives for the scheme basically. So it's a slight change from the end of March version. We've commenced discussions with Welsh Government on the case, and we are seeking board support to further strengthen our discussions with Welsh Government. Happy to take any questions.
Okay, thanks, Mark. I've got John with his hand up. John.
Thanks, Mark. Just to support the changes in the first instance, I think to explore other options, I think helps in terms of the overall process. One minor question on the cover sheet on page 2, it says we envisage 3 closely related strands, but it says it'll be unified across both strands, which implies 2. So is it 3 strands of work or 2 strands of work?
It is. Yeah, so I'm just finding it. It's 3 strands: refresher of living healthier, staying well, clinical services strategy, and a refreshed estate strategy by September this year. So I make that 3 strands.
Okay, so just a slight amendment to the cover sheet then. Thanks, Mark.
Thank you.
Okay, thanks. Jill.
Thank you, Chairman. It's just to support Mark in calling out that further option, which, as he said, was perhaps implicit but not as explicit in the original case. There's a number of reasons that putting forward, not least the pace at which it could potentially be delivered. And we're acutely aware of the long waits that we've got for both diagnostics and elective surgery. So there are a number of reasons why we are exploring that, and are keen to have the conversations further across the board and with our partners.
Thanks. So it seems to me that the debate is turning to not so much the what, but the how in terms of the model of delivery. I mean, I know it will still be around the what, but it's also, there's an adjustment to the how, isn't there, in terms of the options available to us?
Yeah, I think there is, and that's the change that we've made, Mark. I think it's probably fair to say that Welsh Government also had got quite a few questions about the what, in terms of how does this fit with the Health Board's clinical strategy? How does this fit with an approach to planned care? What are we doing immediately on a recovery agenda? So I think Welsh Government's concerns are actually still quite a lot to do with establishing this as a strategically coherent thing to do.
Okay. Then my concern, Mark, is, and of course I understand why they're asking the questions they are. What we certainly don't want, Mark, Joe, Jill, is for this to disappear into a massive toing and throwing around questions, and that we continue to press hard. And I know we are in the submission of this business case for movement forward, given the risk being entered for the patients in North Wales.
Yeah, absolutely.
Right, okay. Joe, then Jill. Thanks.
Thank you, Chair. Just to confirm our absolute commitment to work hard on not only Welsh Government for all of the reasons that you've talked about, but to make sure, as part of the refresh of Living Healthier, Staying Well, and the emerging clinical services plan due for discussion at our board workshop in early June, we are able to place the appropriate strategic context around the development of the diagnostic and treatment centres. So, excuse me, sorry. So our absolute intention is to continue to work in partnership with Welsh Government on each of those component parts. I think in fairness to our colleagues in Welsh Government, the need for capacity is not under any kind of doubt. It's the how best and where best to place that capacity are the considerations that we're working through with our colleagues absolutely now. But the urgency is one of the reasons why we're looking to strongly consider a managed delivery option, because that may bring solutions to us sooner than a traditional capital build. Thank you.
That's helpful. Thanks very much, Joe. Jill?
So Joe's picked up much of what I wanted to say, and absolutely we are progressing the conversations with Welsh Government, so they do know that we're including this as a potential option. And one of the points they raised around our original case was the timeliness of being able to implement, and thus for it to be able to impact on those people that are awaiting plans, diagnostics and surgery, and also to support, and let's be clear, the one-stop and reduction in pathways that we have across some of our more urgent areas of service, including cancer. So those conversations are taking place. They are interested, Mark, in the proposition that we are putting forward. Equally, we are very clear that has to link into the wider objectives of ensuring that this is economically good for North Wales, as well as good for the health of the population.
Thanks, Jill. That's also really helpful. Okay, Mark, thank you. So we're asked to note the change to the SOC and support the development of an outline business case. Are colleagues happy to do that?
Yes.
Yes.
Great.
Yes.
Chuck and Val, thank you, Mark. So again, we'll move on, and we are moving on to the digital strategy. Chris, I don't know if Dylan's joined us yet. I haven't had the time to look, but should we start with your good self in any case?
Absolutely. Thank you, Chair. Another huge effort, and again, another team to thank for their work, this time the IM&T team. Well, I'm going to take the strategy as read, and many of you will have seen it in its journey through subcommittees. Just a couple of comments. This is really useful to us as an organisation, but I can't stress how important it's been for the team actually to have done this. And I mean, they've gone about it with a real gusto. They've worked really hard on engaging with it, thinking creatively and outside the box. And their confidence as a team has demonstrated that it's been really important for them. Looking at the risks, there's a couple just to draw out. The first is the risk that they have identified with regard to digital exclusion. That's an issue which commonly occurs when we talk about these things, and I can report today that the team are taking a very active interest in what they can do to contribute to addressing that. The second goes to some of the conversation a little earlier on in terms of the resource required for digital. I would say that with the conclusion of this piece of work, that risk is lower than it was before, simply because this work very skillfully brings together all of the different strands of work and helps us to prioritise the bits that are really important, the bits that aren't quite as important, and just as importantly helps us to articulate why we might need to put forward cases for investment in other areas. So I think this piece of work will help us to address that shortfall and make best use of the public purse. And on that point, I will leave it and open up for questions, please.
John, shall I come first to you as the before I come to Morwenna, as chair of DIGC? Anything you want to say?
Not specifically in terms of questions, because it's obviously gone through committee, but really just to support the quality of the document, the engagement that's been done, the work of the team, and to commend it going forward. I think it's an excellent piece of work that actually gives us that clear understanding of the way forward, which will, as Chris has said, give the organisation the opportunity to help prioritise where the investment is needed to be able to enable the the improvement in the organisation as a whole.
Thank you, John. Diolch. Morwenna.
Diolch yn fawr iawn. Thank you very much. And thank you, Chris, for the presentation. I would just like to endorse John's comments, really, because I think it is a very exciting strategy, and I'm very pleased to see it in today's pack. There are 2 points I'd like to raise. The first one, and I'm certain it has been considered, but when reading the strategy, I don't feel that the vision and the aspects of what exactly is going to be done around the Welsh language is very clear in the strategy. There is a reference to the standards of the Welsh language and attaining those, but I can't see how this digital strategy is going to go forward and ensure that we don't consider the linguistic requirements after developing the systems. And the period we've lived through with COVID shows how important it is for us to consider the language hand in hand with any developments. And I do chair the More Than Just Words forum, and we did receive, we had a discussion which was very constructive with Dr. Fernley before he left on the use of the forum to help with the digital strategy. So the invitation is there, and the offer is still there. So if we could strengthen that aspect, I think it would be very useful for the population, but also for staff. The second point, in terms of the digital exclusion and digital poverty, as it's called sometimes, a lot of work is taking place. I'm talking now about Gwynedd Council mainly here now, but I'm certain it happens in the other 5 councils. So there may be an opportunity for us to work closely there and make sure we carry out the right interventions to be helping individuals who are digitally excluded within our communities. And a lot of information has become live within this past year. So there's an opportunity to work across the partnerships there. But thank you very much, and I welcome the strategy.
Thanks, Morwenna. I mean, they're both 2 fantastic points. We will take up that offer of the More Than Just Words forum. That's fantastic. I think it's a really well-made point about the Welsh language. I am aware that the team have been thinking more about it than perhaps comes across within the document, so we will look at that too.
Thanks, Morwenna. Diolch. Chris, thank you. Lucy.
Thank you, Chair. Echo really what's been said so far in that it's really great to see this strategy today before us. It's something we've been talking about, and aspiring to for a while, and it's absolutely something that the pandemic has shown us just how much digital can really change the way we work in a positive way if we get it right. I suppose my observation would be that I wonder if, obviously this is a strategy for us here at the Health Board, but with us having a new health minister appointed, I think we may have an opportunity to try and encourage more focus actually on the All Wales digital picture as well. And as you know, Chris, one of my areas of frustration is the lack of an electronic prescribing system that we've got here in Wales, and the inequity of services, between England and Wales. And that's not something that we can fix purely on our own. It is an area that has been discussed as trying to do a bit of a Pathfinder project on it as well.
So before you respond to that, Chris, perhaps one for Joe. So a while back, I had a meeting with Bob Hudson, the chair of the new national body, and I suggested that at the point at which we approved our strategy, Chris, we might want to have a call, Joe, I, you, John, whomsoever, to just share with them our strategy in that call, the chair and chief executive, and to talk about how we encourage a strengthening of that relationship to move our strategy and the national strategy forward. I would certainly suggest that would be a good idea. I don't know what your and Joe's thoughts are on that, but I think we ought to attempt to engage with them collectively. Joe.
I think it's very timely given the confirmation in position of the chief executive now. So subject to Chris's support, I think it's something that we should definitely do.
Thanks, Joe. Chris, you happy with that idea?
Yeah, fantastic.
Okay, I'll get Klinos on it then and get it to liaise with your office, Chris, so we can confirm who else you want there. John?
Thanks. I was just going to reference back for Lucy for the electronic prescribing. It is referenced on page 29 as one of the particular areas of activity projects that need to be addressed. So it's not lost in terms of the document in terms of that as a need.
Thanks, John. Okay, so then are we happy as a group to approve the strategy? Is that a yes?
Yes.
Yes. Yes.
We ought to acknowledge too, I think, that I think this is the first strategy where we've needed to see a social economic duty assessment, and it's good to see one with this document. So thank you. Okay, so the strategy is approved, Chris. In terms of moving it forward, then I had a conversation with Joe the other day. There are about 20 pages, a bit more, Chris, of ambitions and intentions. I assume the next stage will be to give some sense of priority to those and agree how it's going to move forward. Is that the plan?
It's exactly the plan. We're partway through looking at that. So, yeah.
Okay, thank you. Thanks. John, your hand stood up. Are you wanting to come back in? No. All right. No. Thank you. Thanks. Okay. So thanks very much, Chris, to you, Diane, and T. I'm now going to move us on again to the maintaining good governance during COVID item. Point Quek. Louise.
Thanks, Mark. Happy to take this report as read, really, but I think just to say that colleagues will recognise this as an update to previous reports that have been brought to the board about how we have sought to maintain good governance, particularly at board and committee level during the COVID pandemic, recognising the need for appropriate decision making, but also reducing burden and releasing capacity to respond to the pandemic. It is just a position statement and recognises where we are with the current pandemic and actually some of our business returning to something of usual. The main bit I think to tease out is that we are proposing that the COVID cabinet is stepped down as we have done previously. That was invoked as a means of very rapid decision-making, endorsement of decisions that were proposed by the EIMT. And you'll see from the paper that was presented earlier on that has reduced in frequency. We haven't had need for the cabinet since February. So at the moment, it feels the right time to step it down. We do have the facility to reinvoke that very quickly through chair's action, should the need be. So that's the main proposal in the report, but I'm very happy to take any other questions.
Thanks, Louise. So are there any questions or observations? No? Okay, so we're then asked to note and support the update and support the proposal to formally step down the cabinet meeting. Are colleagues happy to support those recommendations?
Yes.
Brilliant. Okay, thank you. Thanks, Louise. So I will move us on again to information items. The first is a board cycle of business, Louise, and it's verbal.
Yes, Mark. I kept this on just to acknowledge that the business cycle would ordinarily have been reported to the board for approval at this stage. However, we've deferred that because at the board meeting in July, the board will be due to receive the full outworkings of the governance review, which colleagues will know has been ongoing and we most recently discussed at the workshop. So at the July board meeting, there will be a suite of papers, including the business cycle for the board, that will come through for approval at that stage.
Thanks, Louise. Okay, so thank you very much for the update. So we'll move on again if you're happy. And that is into the summary of private board business to be reported in public. It has been shared. Our colleagues happy to note the report.
Yes.
Yep. Yes.
Yeah. Move on again. All WOWs and other forums for information only. There is one on the Collaborative Leadership Forum minutes of the 1st of December. It's listed for you, Jill, but it is information only. So I'm going to take it as that. Are we happy to receive that as information?
Yeah.
Great.
Yes.
So I'm now closing the business of the public meeting. The date of the next meeting is the 15th of July. And at this point, I'm excluding the press and the public. Kate, are you dealing with that?